Bismillah ar-Rahman ar-Rahim. Very good morning to everybody here. My name is Amal Ibrahim from UCG. I am the Middle East Organizing Secretary since 3 years, and it's my pleasure to have you all the estimated event hosted by UCG Conferences. The last 2 days was in-person conferences, and the interaction was amazing between the participants in the hall and the online attendees, and hope you are enjoyed your in-person days, even if you are joining us personally or virtually. After each speaker, I will open the questions or comments session. If anyone have any question, just raise your hand or write your questions or comments in the chat box. As we all of us know, UCGs have organized and chaired a lot of medical, health, and engineered events all over the world. We have met a lot of conferences in Germany, Dubai, USA, in San Francisco. As you all know, this is not our first conference in Dubai. And also, I would like to encourage all of you to attend our next conference in the USA. Actually, it will be held in Los Angeles from 15 to 18 November 2023. Also, briefly, I would like to share with you our upcoming conferences for 2024 and 2025. The 14th International Nursing, Healthcare, and Patient Safety Conference from July 25 to 27, 2024, in Holiday Inn Dubai Al Barsha, the same place as we are located now. Also, the 14th American Healthcare Summit from November 12 to 15, 2024 in Texas in the USA. The same conference in 2025 will be in San Francisco, and going on. I would like to estimate my pleasure to introduce our first online speaker for today, my friend and my colleague, amazing speaker who was met in Riyadh 1 month ago, my friend Miss Anit Van from KSA. I'm passing here the stage to deliver the speech on non-compliance and type 1 diabetes treatment plan. Before Miss Anit starts her presentation, I would like to apologize for the internet connections, and let's her start her speech in a hurry. My dear, the stage is yours. We can't hear you.
I am on now. Can you hear me now?
Yes. Yes, please.
Okay, good morning. My name is Annette van Ginkel. Oh, you know what? Do you think it's on my other one? It's echoing. Is it echoing by you or by me?
I can hear your voice and I can see you clearly.
But echoing? Oh, there it's gone. It's not echoing anymore. Okay, like I said, my name is Annette van Ginkel. So I am so happy to see you again. It was very nice to see you in Riyadh, and I think soon again. I am a nurse for 39 years, and in critical care I am for 26. So at this moment, I'm at the end of my career, and I start doing chronic diseases. I'm also a health and wellness coach, and my niche is chronic diseases, to make sure that people are compliant to their treatment plan. The doctor is still there because the doctor needs to prescribe, but our patients are not compliant. And you know what I actually realized? It's not always their fault. So I'm going to share my presentation and my screen. Oh, no. You know, you will see I can speak many languages. Oh, how do I do it now? Sorry, Amal. I want to, I did open it, but it didn't want to take, it didn't want to do it. Now let me just make, where is my one?
You can share your screen, please.
Yep, I've got it now, and it's
press
just
the The green
Now
icon? And
you know what the problem is? Now you are small. Wait, here you are big. That's it.
okay. Finally.
Yeah, finally, you see it?
Yes, we can see it. Start, please.
Okay. So what I want to say to you, let me just do a slideshow. I want to talk about type 1 diabetics non-compliance. The big thing is I want to talk about children because elderly, most of them are type 2 and they can make decisions for themselves. So this is a diabetic child. So what is type 1 diabetic? It's known as juvenile diabetes from insulin-dependent diabetes. So chronic disease, the pancreas makes little or no insulin. And this is the difference from type 2. This is where the pancreas is having a problem. So insulin is a hormone in the body used to allow sugar or glucose to enter the cells to produce energy. They don't have any insulin. Different factors such as genetics, some viruses may cause type 1 diabetes. Although type 1 diabetes usually appears during childhood or adolescence, it can also happen in adults. And after a lot of research, type 1 diabetes has no cure until now. Maybe one day. So how do you diagnose it? Suddenly strange behavior, breath smells fruity, extreme drowsiness or lack of energy, ongoing intense thirst, grunting while breathing, heavy breathing, huge appetite, sudden vision changes, sudden weight loss, pass urine more often, difficulty in breathing. If you look at this, a lot of viruses can do the same thing. It's not only diabetes. So when you have this child, there's certain things that can give you an idea. Normally, when we get type 1 diabetics in hospital and in your ICU, it's because they've got DKA. And then they are diagnosed. And most of the patients that I see, I'm working in a PICU at the moment, and this is what we're seeing. And then they get diagnosed. What causes it? The beta cells in the pancreas are attacked and destroyed by the child's own immune system. So then there is no insulin. Started by environmental triggers in a person that have genetic to develop an autoimmune disorder. Signs and symptoms, I also told you earlier, it's that there's hidden signs like bleeding gums, high blood pressure, digestive problems, fatigue, confusion, slow healing wounds, burning feet, including numbness and tingling. How do we diagnose it? Blood sugar testing, you test the fast blood glucose, random blood glucose, HbA1c, and then we also do tests for presence of antibodies. And if the patient comes to ICU, we normally do a lot of tests, and also very often we do the blood gas because you want to see what the lactate is and the bicarb is. So treatment is normally a multidisciplinary team approach. It's not only the endocrinologist or the doctor. You need a pediatric endocrinologist to look after children, nurse, diabetic educators, nutritionist. Then also you're going to get your podiatrist and all those things. Did you know that 10% of all diabetics are type 1 diabetics? But what people don't know is that children with diabetes got rights. And they are qualified for special education. How many diabetic children get special education? I don't know of any. There's a lot of research things that I will tell you about later, like in Australia, America. It's in their white paper written that these children are allowed to test them, are allowed to eat, and all those things. They don't need to go to special schools. But the teachers need to be knowledgeable and those things. And I don't know if our teachers are knowledgeable. So diabetes, they always have some burden to overcome. and it's not easy for these kids. If you look at toddlers, they are picky eaters, they do temper tantrums, quick in growth and development. So you start them on a regimen, like carb counting, you start them in the insulin. But if you give insulin, and this child is a picky eater, you have a problem, because you already give the insulin. What is going to happen to the blood glucose of the toddler? And imagine these children that you need to prick when they come in hospital, like in ICU, we prick them every hour. You want to see what the glucose are, and then we give them extra fluid. It's very frightening for these little ones. Preschool and early school, 3 to 12 years old, they need assistance with testing and administering insulin. When they are diagnosed later, they need to cope with the diagnosis. So if it's a small child, they grow up. But say now you've got an 8-year-old or 9-year-old, immediately they are scared. This is needles. This is checking their food. It's a very, very expensive hobby. Psychological challenge, peer pressure and bullying. Some children will say to you, this children ask me, what is this on my arm? And they're making jokes. So this child gets isolated. Managing their blood glucose when at school, they get depression, anxiety, and also behavioral changes. We all know children with chronic diseases, they are very, very, very manipulative. Teens, this is our biggest problem. They have a challenge to be independent. I will choose. I will do whatever I want to do. Too much parental involvement can alienate a young person. They will fight you all the way. They want to decide for themselves. Peer pressure again. They go to a party and everybody's eating nice things, and now suddenly they can't. Attitude towards authority figures. You know that they will fight the parents, the healthcare team, the teachers, everybody around them. Why do they have a challenge in adherence to the treatment plan? Psychological factors. They will feel isolated. They will feel depressed. They can get bullied. Social factors. Imagine you come out of a not so well financial family. Now your family needs to buy a bread and fruit and those things. Your insulin cost 1,000 rand. I don't know how much is in dollars. Your testing things that is only valid for 2 weeks, you need 2 a month, is 1,200 per one. Imagine the government hospitals is not giving you the testing tools. They don't give you the insulin, so it comes out of your own parents' pockets. Parental influence. The person that I want to talk a little bit later about, his mom is not, she's not a present mom. So she doesn't help him to make good choices. And he's only 8 years old. His father is there, and his father got a lot of influence. Then you get the mother say, oh, he's a diabetic, oh shame, and give him a cookie or give him soda and everything. That it's become a habit. Peer influence. We do know with asthmatics that some of the children will steal the children's asthmatic pumps, and they will waste it. So what is happening if they steal this child's insulin or break its testing apparatus? What is going to happen to this child? And the peer influence also by bullying and making jokes and tell them what to do. Healthcare availability. I know that you know that the healthcare try their best. All of us working in some way in healthcare. There is not enough consumables, there's not enough resources, and some people are staying very far from the healthcare facility. How are they going to get their equipment? And diabetic care support. Some people stay in rural areas and they need to travel by public transport, and it costs them a lot. It can be hours before they reach the nearest hospital just to not to get the support they actually are supposed to have. What does children need? They need education. They're not too small. I see small kids that can actually understand. They need support. They need to have education regarding testing and administering insulin. So all children need education. So if there's a child in the class, they need to teach all the children in the class regarding diabetes and what the teachers can do. You know, all these days in my country, all these days I teach them only about TB and HIV. There's other diseases like asthma, like dyslexia, like, you know, some mental issues, but they don't get taught that things. Learn how to count carbohydrates. This is time consuming. This is very stressful for the parents and also for the children. The effect of the diagnosis on children, they feel that they are a burden on the family. Because now everybody's plans must go around to this child. Okay, we're going to go to a park. Okay, where is your insulin? Where is your food? Where is your snacks? What are you planning to do? They are treated differently, especially in the beginning, because now it's a new way of thinking, a new way of living. And now they feel like they are different. They feel overwhelmed due to the constant questions about what they ate. I will go, what did you eat today? How much insulin did you give? How do you feel? All those things. Other siblings can have feelings of jealousy. School-age children, they need support from their teachers and friends. So according to the white paper, it says that in every school, teachers must be taught how to care for children with diabetes. They need to know about the insulin. They need to know about the testing. Emergency contact numbers must always be available. It's the task of the parent to give all that numbers. This is the parent's numbers. This is the doctor's numbers. This is the ambulance number, all those things. And children carry their testing equipment and insulin always with them. So imagine they've got the bag full of books, and then they've got testing and also food. Teenage children, they are the problem. Education and support regarding alcohol use. Remember, they start going to parties. Drug use, smoking, sex, body piercings, body image, eating disorders, diabetes, and driving. Eating disorders is a very big problem with diabetics when they are teenagers, because what they want to do, some of them gain a little bit of weight, and then they want to stop eating because they want to be the same as their friends. What is DKA? It's recurrent DKA is a sign of poor control, inadequate parenting, single parenting, lack of family involvement, financial stress, and insulin omission. And that is a maladaptive coping strategy. Some children will deliberate not take the insulin. They will deliberate not eating. And we see recurrent DKA a sign of poor control. Then the team must come in and a team must assist. What is the reality? The adolescent has psychological changes and increased insulin resistance. They experiment. They are risk takers. And fear, you can tell them, if you don't listen and you don't adhere to this plan, you're going to get blind, you're going to lose a limb. They're not scared. I'm young. It's not going to happen to me. When starting on insulin, they do weight gain, and it's very difficult for girls. Especially they gain it at the mid area. So look at this glucose testing equipment. On the left side, it's old ones. Imagine you need a machine, you need lancets, you need a stick, and you need it for the whole month. And then you need to clean the area where you're going to prick yourself. Now these days, you've got this type of freestyle things. And it makes a very big difference with our compliance of our children, because they've got this little machine upstairs. And then if you look at the freestyle library, it's a little button that they've got. I will show you here. They put it like this. And then what's happening, it continuously tell you what your glucose is. Or what you need to do, at least for 4 times a day, you must scan. And that's easy. That is very easy, but it's very expensive. And it's not always available. If I look in Saudi Arabia, the Libre 3 is already here. If I look in South Africa, they still sit with Libre 1. And it's not even part of the government. The government don't have it. So these poor parents must pay it out of their pockets. And a lot of the children don't have medical aids. So some of the medical aid starts paying for this. So then you go to your insulin. If you look here, this was the normal insulin that we normally have. Now these days you've got pens. It makes it so easy, because if you make a mistake, they can actually put it, dial it back. And it's easy for the children. Imagine a child must look onto this syringe to look for 2 units, 3 units, 4 units, where this is much better. And the latest technology is the insulin pump. I don't know how many people can afford it. If I look in Saudi riyals, it's like 50,000 Saudi riyals. It's sometimes times 5. In my country, it's times 5. Which patient can afford that? Look at this child. There it is. Look at this child. Can you see? Other children can see and say, oh, what is that on your arm? And this is the problem, because they can get bullied because they are different from other people. Look at this little one. He's wearing the insulin pump by him. Luckily, they learn quickly. This one there, she's got her food. This is her bag. And it's a lot of work for them. This child is so young and is injecting himself. What services are available? Family support network. Collaboration between Disney and Lilly, which provides fun diabetes support in various ways. They've got fun days, and all type of diabetic children goes there, and they get taught and they get played and all those things. Then there is a Juvenile Diabetes Research Foundation, American Diabetes Association, diabetic camps. This is very nice. I think they do it in other countries. Not a lot of people do it. The diabetic camps is where these children can actually live with other children who have diabetes, and they can feel like they do the same. Free access to diabetic care. Unfortunately, this is not there. And there's a lot of advocate groups. I am actually part of an advocate group to advocate for our kids, to get the treatment that they are entitled to. And then you need your diabetic care team. Here is what I want to say to it. What is the government responsibility? Federal law gives students the right to receive diabetes care. They need to be safe and participate in school activities, just like any other child. So I got this from different places. The same happens in Australia. National Diabetes Service Scheme provides subsidized products and support services to people with diabetes who registered within the scheme. Not all countries are so lucky. What is the challenges is the cost and the access to medication, especially in Africa. How can they test if they cannot even get to the hospitals? How can they test if they cannot even afford the insulin? They cannot even afford the correct food. The major burden of diabetes increasingly falls on low and middle income countries and impacts disproportionately on poorer, disadvantaged, and vulnerable groups. So this is bad because it means that the rich are getting helped. But if you don't have it, what is going to happen to your child? And the best thing of it is, it's not even their fault. It's not because they've got poor eating habits. It's because it's their pancreas. I want to tell you a story. Can you see this boy? He's only 8 years old. He is 41 kilograms. So he's a type 1 diabetic. He was in ICU for more than a week because of DKA. And that was the first time that he was diagnosed with diabetes. So it cost his family a lot of money to keep him in ICU because it was not subsidized by the government. So I went back home and I actually grabbed this little boy, and he's a boy with attitude. Here, I taught him to give his own insulin within 3 days. From I pick him up to take him to his father, I will not give you insulin. I started teaching him about his sensor. I taught him, okay, this is your glucose. What do you think we must give you, the insulin you must give? What food you must have? And within 3 days, I got his insulin, or his glucose much better. Look how he looks now. He's active. And this little one was challenging me every way. And unfortunately, or fortunately for him, I could say to him, I will take out all your teeth because he's my brother's son. But you cannot say that to your patient. So look how he looks like. He's back in school. He's actually doing so well. When I got him, look at what his sensor says. High, 27, 27, high. And that happens all in March. Look what's happening now. It's 7. His target is between 6 and 10. And then he must eat accordingly. Do you think that he actually needs support? He doesn't need so much support. He can manage his own insulin, he manages his own food and carb counting. So this is where you want your children to be. They need to understand what the big problem is with these children. They do well and then suddenly they get tired. Also, the parents get exhausted because it's the whole time checking the glucose, checking what they eat, and it's this special food and this special food. But you can give them some vacation. And you can say, okay, tomorrow is a vacation day. Let us see what you can eat, but teach them to do the best choices. And they can do. This boy is really doing well. So we need to advocate for our children. And we need to make sure that our governments are knowledgeable regarding this problem. So this is my presentation. I hope it helps. I hope that you can see that it's not always our patients' fault. We want them to be compliant. We want them to be safe, but we don't provide them that. I don't know, nurses and doctors, we want it, but there's no facilities.
Of course, my dear. Thank you very much, my dear Annette, for your amazing and informative topic. If there is any questions, just please raise your hand or type it in the chat box. Before actually I will start my questions.
Too much, I'm sure.
Let's check the chat box first. اوكي دكتور عادل باطوي. صباح الخير دكتور عادل.
صباح النور، يعطيكم العافية. Thank you very much. يعطيكم العافية.
الله يعافيك يا الله يعافيك.
Since no one raised their hands or so I thought I'll utilize this so it doesn't take on my time. Yes, it is an issue. The diabetes, actually, in general, compliance and adherence to treatment is something Whether actually you can afford the treatment or not, it's an issue, by the way. Even in Saudi Arabia, actually, my next project of research is on adherence to treatment for diabetes 1, 2, and obesity, endocrine. It's not about really, okay, your perspective is about children, but from my perspective, it's the adults that they can afford everything. But why? So really, I'm looking at it from the personality point of view, traits and psychological issues. So this is my next project, and with the little boy, they must have an attitude, because this is the makeup. This is how they are. They actually. It's part, sadly, I mean, the makeup, the genetic, and the personality traits, it makes them actually susceptible to diabetes, and it actually reflects also how they look at life, and whether they are attitude or stubborn. It's and even the cortisol or the A1C is affected by who they are. So it is a sad thing. It's not about actually background, socio-economic. No, rich people or poor people can be diabetic 1 and 2, and of course obesity. It's a sad thing. It's another thing. So well done is something that really it is an issue, even here, which is something that I'll be inshallah doing within my next research. So thank you very much.
You know what I saw in Saudi? In the hospital where I work, if you are legible there, they get everything for free. But still, what you said, attitude, make them not compliant. And this is the problem. I believe, sorry, you don't need everything for free. When I look at after this boy, 3 days, yes, he challenged me. But when he sees if he exercises, blood glucose is better. If he eats better, he can have that little bit of ketchup. It changed so much. But I know also they get very tired because it's the whole day checking and checking. But yeah, children are not so easy. But we must teach them, and we must be a role model. If I look at my brother, it's the same as his son. And that helps a lot. It's not like other people in the house is eating different things. So it's out there is somebody is doing the same as me. It's difficult for them.
Thank you. Yes. Not just children, even adults can be difficult, but okay.
Of course, when they're old, they're like 70s, they say, my whole life I eat like this. You're not going to tell me. And there's where I say, Khalas, honey worry.
Thank you.
Is there any more comments or questions? Okay, actually, I have 2 questions, my dear. The first one, in your opinion, what is the risk of continuing non-compliance with diabetes?
You know what? They will get blind. They will lose a limb. They will get infections. And remember, every time when you're in hospital with a DKA, there's a lot of kidney disease because all this acid and lactate is actually damaging the kidneys. So they need to understand this. But like I said, teenagers is not scared. I know about people who they were diagnosed when they were smaller. When they are 21, they are blind. And then when they may be 28, they actually died of complications. And that is what we want to prevent. We want to prevent the complications. And they are really, you just need to teach them and you need to tell them, but don't make them scared. Don't make them, this is a scare diagnosis, and don't make it only doom. You must assist them.
Definitely. The second question is, what are the reasons for non-compliance with insulin?
With insulin, it's a needle, and okay, you can say it's attitude. I don't want to carry, I don't want to see people when I'm injecting myself. It is not looking good. Oh, I'm going to gain weight. That is normally the girlies. I'm going to gain weight. And also the insulin needs to be stored in a certain way. And it's too much. It's always carrying this burden with you. If you have an insulin pump, it's also a big baggage the whole time. I must say, I never even saw a child on an insulin pump because it's very expensive. But maybe Dr. Adel can invite me, that I can go to his clinic and whatever, because for me, it's also good to get training. And I don't say anybody must pay me. It's more education for me. How do you tell this child to carry these things with them the whole time? What sport can they do? And then the availability. When I look at this child that I helped, he was on a short-acting insulin and a long-acting. The short-acting was not available. So what did they give him? The middle one, the one that's short-acting and long-acting. It's wrong. So his blood glucose will not be managed. Yeah, so it is hard.
Thank you very much for answering my questions and for informative topics. I will advise you to continue staying with us because our next speaker have an amazing presentation. So our next poster presentation is by Dr. Elizabeth Reins from USA. Please inform me if I pronunciate the name correctly or wrong. I'm passing her the stage to deliver the presentation and the simulation and improving clinical judgment in resilience nursing students, a mixed method approach. Dr. Lisa, the stage is yours.
Thank you. Thank you. And thank you for pronouncing my name. That was correct.
Okay, thank you.
Okay, yeah. Thank you for this opportunity. And I'll go ahead and start sharing.
Yes, please. Perfect, we can see it.
Yeah, I'm going to put it in a different. Okay, I appreciate this opportunity, and I'm happy to speak to you all about my study. And I've been in, my background is critical care and nursing education, and I've been a nurse for several decades. So the name of my research is Simulation and Improving Clinical Judgment in Pre-Licensure Nursing Students, a mixed method approach. And so first of all, I'd like to ask what is the problem? We continue to have ongoing challenges in training nurses within the healthcare system, especially since the recent COVID-19 pandemic that barred clinical experiences contributing to these challenges. In addition, there are ongoing demands in healthcare that increase what bedside nurses need to know and do in a dynamic and challenging healthcare environment, which leaves us with the fact that nursing students and newly graduated nurses must learn to quickly navigate the complexity of the healthcare setting while exercising sound clinical judgment. So the problem statement asks, how does simulation help improve nursing students' clinical judgment? Again, I used a mixed method study to better understand by using the Lasker Clinical Judgment Rubric, or the LCJR, to quantitatively rate and compare student groups. I also added qualitative data to provide more depth and breadth to the quantitative measurement. So the purpose of the study, mixed method approach to examine how simulation improves clinical judgment throughout the nursing curriculum by use of the LCJR, while observing and comparing beginner pre-licensure nursing students to advanced pre-licensure nursing students observed during their regularly scheduled high fidelity and multi-patient simulation classes. The literature reports that the healthcare simulation has been rapidly developing as a valid learning methodology to help with these challenges. Along with the ever-increasing shortage of clinical sites within a rapidly changing healthcare environment, it is now more important than ever to provide consistent clinical alternatives. Research continues to report the time-consuming challenges in training newly graduated nurses, as it still remains significant, along with the fact that 70% of medical errors are associated with the breakdown in the system, particularly in communication, as nurses are implicated along with this. So while faced with the challenge of transitioning to practice, the newly graduated nurse must simultaneously learn to navigate a complex system such as healthcare, while developing as a beginning practitioner in a safe and effective way. Since the beginning of the pandemic, studies have proliferated documenting the experiences of educating and training nursing students in this newly restrictive environment. The pandemic has taught healthcare academia much, namely how to maintain the educative process by utilizing as many modalities as possible while heightening the benefits of the clinical experience. Specifically, the literature also points out that cognitive failure and barriers to critical thinking will affect proper clinical judgment development. And these gaps and barriers led to failure to detect changes in patient condition, leading to deterioration and demise, and were identified in 75% of the situations. So the research questions were asked overall. What is the understanding of how clinical judgment improves following simulation experience within the nursing curriculum from a quantitative and qualitative standpoint? Specifically, 3 questions were asked. Number 1, what was the relationship between clinical nursing simulation and clinical judgment? Number 2, what was the difference in clinical judgment between cohort A, the beginning student, and cohort B, the advanced student? And 3, what were the experiences of nursing students and clinical judgment post-simulation? Now we'll move on to the methods, data analysis and procedures. First,
Excuse me, I would like to inform you that your slide is not moving.
Oh,
Can you check
okay.
with
So you don't see the present slide?
Actually, we are in the slide that names methods, data analysis, and the procedures. It's
Yeah,
for me,
that's the
but for
one.
the Mhm.
That's correct. That's correct. That's the correct slide. So
Okay.
yeah. So the theoretical conceptual framework for this study was based on the Tanner's model of clinical judgment, as you can see here to your right. The development of the Lasseter clinical judgment rubric is based on the Tanner's model of clinical judgment. The Tanner model includes the clinical judgment processes, which include noticing, interpreting, responding, and reflecting. And as you can see, the LCJR dimensional subsets are delineated for each Tanner process. And it was these particular subset constructs that were studied within the groups for this study. So I'll just kind of highlight. So for noticing, we have focused observation, recognizing deviations from expected patterns, information seeking. They take that information and then they interpret it, and then they prioritize their data, and then they make sense of their data. And then they move on to responding, and how they respond would be, would they respond in a calm, confident manner? Would they be using clear communication? Would they have well-planned intervention, showing flexibility with that? And would they show skillfulness? And then finally, with reflecting, they would evaluate or self-analyze how they did, and then they would express any commitment to improvement for the future. So this was how the students were quantitatively and qualitatively observed and ranked. Now looking at the methods, the rationale for the research design paradigm juxtaposed the quantitative and qualitative right here to understand how simulation improves clinical judgment. The sources of the data included the 2 dimensions of data, which were the direct observations and quantitative ratings of student groups practicing clinical judgment during simulation using the LCJR. The other aspect was the interpretive work, including the qualitative analysis of field notes and post-reflection logs, post-simulation reflection logs. And the reliability and the validity of the LCJR is well documented in the research. In terms of the trustworthiness of the qualitative data, reflexivity was used to maintain credibility and objectivity. Triangulation was used quite often to cross-check coded themes. These themes were derived from the field notes that were gathered during observations and the post-simulation reflection logs. The reflexivity protocol was utilized as the researcher myself. I was the sole rater, so there was no inter-rater reliability for quantitative scores. Rather, using the qualitative data and a trusted colleague with equal experience and education check the qualitative data for appropriate coding alongside the quantitative scoring. I maintained a non-biased, unobtrusive posture stance during observations, and I used a recording sheet to keep emic and etic observations true to form. As far as the procedure goes, the simulation suite is designed for one-way unobtrusive viewing. And so the simulation room is described as the fishbowl. So that was one area of observation. And the other area was the open lab, where the multi-patient simulation took place, allowing for roaming and positioning myself to observe and record unobtrusively. For data sources, research data source 1 was the quantitative analysis that include the observed numerical findings provided by the LCJR, and they were presented in aggregate form. The various subsets were pulled out and compared the beginner to the advanced student using the unpaired t-test for separate means on the LCJR scale. The data source 2 were field notes, which revealed codes and themes revolving around confidence, prioritization, fear, communication, problem solving, patient safety, and more. And then the last data source was from the simulation logs, post-simulation logs, which provided a rich description of students' thought processes. The participants were recruited from a suburban college from the Pacific Northwest in the United States. The groups were divided into groups A and B. So they were the beginner and then the advanced groups, for a total of 128 students or participants. Now we'll look at the results. And I'll just tell you what the demographics of the groups were. So for age and GPA, the mean age difference was 4.5 years, with fundamental students being younger on average. For GPA, there was no demonstrated difference in mean scores between groups. For gender, Group A had a higher percentage of males versus females, with a 13.7% difference. And then for students, for participants that were from their country of origin outside of the United States, cohort A demonstrated a 4.8% difference as compared to cohort B. So they had more students from outside of the United States for country of origin. Now we're going to address those first two questions that I spoke of earlier using the SPSS software, running the independent t-test. We'll look here and we can look at the quantitative scores. And I'm just going to summarize this table by saying that all mean and subset scores showed significant difference between cohort A and B, with cohort B scoring greater than A with a significance of P 0.001. And then with Cohen's D, we see an effect size of a moderate to moderately high. So a fairly good, strong, practical application in real world with these scores. Now we'll look at the green table, and we're looking again at answering those questions 1 and 2 using the qualitative data, which helps substantiate the quantitative scoring. So again, looking at Tanner's clinical judgment model, we're looking at noticing. And so cohort A's ability, that's the beginners group, to notice patient cue and changes were more fragmented. Their assessments more singular, and further assessments of what was going on in the simulation required more cues from the instructor. Whereas with cohort B, their ability to notice patient cues and changes were fluid and ongoing. They were well orchestrated within other nursing actions, such as implementations, and they could pick up on subtle cues and target or focus on areas of patient change. For interpreting, cohort's A ability to interpret what was noticed would appear challenged and uncoordinated with other component behaviors, as the group might outwardly question what they saw, guessing on what was going on, and requiring frequent timeouts. Versus the cohort B, they could interpret and gather data and cues while they were multitasking with other skills and behaviors. So they showed agility, and then they could further adjust other approaches and analysis and implementations very fluidly. For responding, cohort A's responses, they could be incorrect at times, and they would require self or team correction quite frequently. Their responses lacked a stepwise approach, and they required, as I said, frequent timeouts for further strategizing. Whereas with cohort B, they could seamlessly adjust, they could coordinate with each other or with themselves, and act with confidence and assertiveness while doing so. And then lastly, for reflecting, cohort A's ability to reflect required frequent prompting, especially for commitment for improvement in the future from the instructors. They required lots of guidance there, versus cohort B, there are more advanced students who were able to reflect more cathartically with purposeful ideas for future improvement in practice and patient care. And then lastly, the third question, which asked about the post-simulation experience or analysis, and overall, students equally expressed roles. They talked about their roles and how they could optimize for future simulation experiences, how they could improve for the future while examining their thoughts and feelings throughout the simulation experience, equally expressing emotion and engagement throughout. And so just to summarize, with the quantitative data, the first null hypothesis was rejected. So the analysis did conclude that the simulation did increase clinical judgment between cohort groups with significant differences in mean and component LCJR scores. Additionally, the analysis also rejected the second null hypothesis, which stated there would be no significant differences. Simulation challenges clinical judgment through processes through communication, and the LCJR is very heavily reliant on communication to capture subset responses and actions within each component. Also, the research is conflicted on how diversity affects the aggregate, but this research I found diversity made a significant contribution to the improvement of clinical judgment. And so I would just like to say that I have recommendations in terms of future research, which can revolve around videotaping, expert modeling, using other theories along with Tanner's theory to study clinical judgment, looking at more at communication itself and other cognitive and physiological parameters. Additionally, for future practice, looking at recommendations revolving around safety. Are students becoming more sim savvy as they progress through their their curriculum, looking at pre-briefing, queuing, and debriefing more thoroughly. So I'd just like to conclude that industry continues to express the urgent need for newly graduated nurses to demonstrate a certain level of clinical judgment necessary to provide safe and effective patient care. Using the LCJR within this mixed method research helped identify how simulation can increase clinical judgment skills in students as they progress throughout their curriculum. And I'd like to thank you for your time. And if you'd like to read the full study, it's found in ProQuest and the Sigma Theta Tau repository. So the next slide is just some of the references, seminal references. So thank you.
Thank you, Dr. Lisa, for this amazing presentation. I know that you are in a hurry, so for me there is no question. If there is any questions or any comments for Dr. Lisa, just please raise your hand or type it in the chat box. Yes, Dr. Adel.
I will wait if there's any questions for anyone. Or comment, please cut me off. Sorry, what was your name? Not Lisa.
Yes, Elizabeth Lorenz, but you can call me Lisa.
Yeah, Lisa. Okay, it's fine. Anyway, I was going to say, yes, simulation is excellent, and we do have a full department in our city, we call it medical city, for simulation. Simulation is excellent, and I agree. It's also part of risk management because my role for the last maybe 15 years is investigating center events at our city. I'm responsible for investigation center events and things like that, particular errors. Simulation helps, excellent, and I do recommend it, and I agree. But the issue is as well, we have to be realistic with scenarios because it's written scenarios, prepared and all that, where it's really, it will lower the skill base errors. But you have to remember that, you know, some of the center events, rule-based and knowledge-based, so within the scenario, maybe in the future, we have to really understand that a routine thing is something that the error is very, very minimal, and then we can, of course, enhance it even further. But maybe in the real life as well, is it an issue where even with the simulation for IV for nurses, the IV infiltration or extravasation, the issue is as well is it's like met with the competencies, met and not met. But really, met and not met does not cater for small variation between nurses. And also within nurses, some actually, whether the medical or surgical or intensive care, the variation in personality and judgment and skills of cognitive is huge. Okay, so these variations really poses a lot of challenges in healthcare because of their ability, cognitive ability. By the background is in cognitive, psychology. It's something that we really need to take into account, that the variations in ability or attributes, characteristics of our healthcare a lot. And even with residents, when I deal with residents, they are actually, some residents are into surgery, but some are medical because of their construct, the way they think, the way they perceive. And don't forget the stress as well. The stress situation in the simulation will be different in real life. So how you cope with stress is something that will affect your judgment, okay, medical judgment. So I thought just something to share with you and with the audience. Thank you very much.
Yeah, thank you for that. Thank you for sharing. There's a lot in my study. I do speak about, the stressfulness that can be, kind of added into the simulation, and that was seen during these observations. There was a code blue simulation, and then with multi-patient simulation, it was to mock like an emergency room. setting, and there were a lot of patients and families. They had a mixture of simulators and actors, and so patients, crying babies, parents, demanding parents, and just all kinds of like factors being thrown at the advanced students. So they were really tested. And so it really attested to the fact that they had come so far in their curriculum, and they had been working through simulations all the way through in kind of a progressive way. So I think it definitely needs to be well thought out, well orchestrated, and the instructors need to be skilled and educated in good simulation methodology. So, yeah.
Thank you, my dear, for a great presentation, and thank you, Dr. Adel, for your question. I would like to ask you to join us because our next speaker, Dr. Adel, have an amazing presentation. Let's continue with our next speaker of day 3 is Dr. Adel Omar Batawil, the Risk Management and Patient Safety Manager at King Fahd Medical City. I'm passing him the stage to deliver his speech on personality traits, thinking styles, and emotional intelligence in nursing towards healthcare providers, characterizations, and safer patient care. So welcome him to the stage.
Can you hear me? Okay.
Yes, we can hear you first, Doctor.
Yeah,
Yes, you can start.
and you can see the. Okay, thank you very much. Really, thank you very much for this opportunity. Thank you, everyone. Yes, the previous 2 presentations are really excellent, and it's something that really is part. It's something that almost I do daily. To be honest, I deal with the simulation people a lot, and it's part of really trying to reduce the medical errors, and not just medical errors, of course. Trying to actually enhance the skills, and there's a lot of wonderful thing about simulation. So I applaud that, and also applaud Anita about the compliance or adherence with medication is another issue for our patients. And actually, it's in the heart of my presentation. I'm sure 20 odd minutes is not enough, but my aim really just to get the concept of the understanding, the thinking, the thought behind what I'm doing. I said to you, I dealt with the investigation event for the last at least 15 years. King Fahd Medical City, as part of the Patient Safety and Risk Management Administration. And it is something that where even yesterday with the miscommunication, presentation, it's something that there's a lot of issues in our field that is unique and different. So we have to, in my opinion, what I'm trying to aim is really just change the mindset of management and the researchers for healthcare to maybe to even, of course, quality and risk management and safety to think maybe slightly different. This is at least my approach for the last, at least trying to see how we can improve actually things. This is my contact details for any really issues, and this paper is about nursing. But okay, let me just first of King Fahd Medical City. It's in Riyadh, and it is tertiary care, and it's now part of a cluster where we have the tertiary care ourselves, and then we have secondary hospitals, and then we have over 100, primary care centers. We started in 2004, but really it's been older than that. We deal annually with more than 500,000 outpatients and 30,000 inpatients. We have main hospital, children hospital, women's specialized hospital, rehabilitation, NNI, National Neuroscience, King's and High Heart Center, and Cancer Center, and obesity and crime. The way that things are now is we have the patient center and all healthcare providers around the patient, which is fine. I mean, it is a patient should be really our care should be patient-centered. But the way I look at it, really, when it comes to medical errors and things like that, the healthcare really staff is actually in the center of anything, and the patient and everything around the healthcare provider is affecting the healthcare provider and the patient. So you have the patient, the task structure, whether it actually is a routine or space, and the environment and the facility, and the communication between the him and or her and the other healthcare providers. And then within the healthcare provider is the cognitive ability, okay, or the construct of characteristics, attributes, okay, of the healthcare provider, which is something that really I want the mindset of healthcare organization to start really looking at, because you can have a system improvement or facility or system. But the issue is here, I'm trying to say, is you have a system, and then you have system and person interaction, but also you have person within him or herself interactions that actually affect and get affected by the system. So really, most of the time, our focus is on the system rather than the person or him or herself, which can affect and get affected by what's around him or her and the judgment. And we have to remember that standardization is excellent, and I do, of course, applaud that and push for it, whether it is checklists or acronyms, for communications and all that, blah, blah. However, we have to remember fixing or making one solution for all is not really the way forward if we want to reduce errors. As simple as that. This is my opinion here, professional opinion. Because now you're forcing all the providers to fit in within that that solution. Perception is really is very dangerous. I mean, this little girl, she's holding the fish and she's really extremely happy. And the reason why she's happy because she thinks that she saved the fish from drowning. And this is actually reality. You could look at this as a nurse or any healthcare provider, and behind her there's her dad. Could be the charge nurse, head nurse, director of nursing, and you name it. And you can see the disconnect and the huge difference between the perception of this little girl when holding maybe a patient, thinking that maybe he or she is saving the patient, but we might be doing harm, and we have to accept we do harm as part of our dealing and our ability and skills and perceptions. And the same for this poor rhino. He thinks that he's doing the correct thing and adding this whatever he sees, because this is all he sees as reality. And the same, the disconnect between this IT really technician and this his boss, that by sending the CD to the cloud, I'm actually saving the data in the cloud. And the same here, how we perceive ourselves, and then the miscommunication, of course. I believe it is 9, and the other would believe 6, and hardly they would believe. And actually, it will be create conflict, which is also, by the way, my current research. I'm finishing now with nurses about bullying and violence, and it's something that it's a reality. Everyone in quality and patient safety and risk management, by Deming and Crosby and all that, so on and so forth. And here Deming says workers are responsible for only 10 to 20% of quality programs, and 80 to 90% is management control. I do agree and disagree. I agree with him and Crosby, with everyone that aspect. I agree with them within their own context. Within their own context, with their background, they come from whether engineers or psychologists or whatever it is. But the industry is a machine. It's not really human. intensive like ours. So I really think we need a paradigm shift here, and because most of the time, as of course, of course, but as in CP2, I teach it as well, is people concentrate on these quality gurus and things like that. So it is a system machine, and actually the human is a component. So I do agree here with Deming and Crosby and others that it's the system and the management control, because the human is part of that system, right? And the driving force is the machine. Whereas in our industry, it's a human system. Okay? Here is the left is certain, he is uncertain. And the machine is part of it, okay, whether it's CT scan or MRI or any really machine. It's you are the system. The human is the system. He is the machine, and you're part of it. The machine is part of you, which is this is if we want to reduce really medical error, we need to maybe do this paradigm shift. Why is that? Because in general, we are very okay. Right, we are actually complex system, right, and very dangerous as well, more than anything else. Actually, we are more dangerous than even nuclear power, because nuclear power and car industry and things like that, they are complicated system where certainty is very high, and you will know for every little screw when will it fail. Okay, and so complex system, that's us, is if you the definition is a complex definition is a collection of individual agents with the freedom to act, and this is it. Each one of us is a system with the freedom to act, with all our construct, with all our personality traits and psychopathy and issues. Okay, so it's complex system is fuzzy, okay, and it's rigid, and it depends on the agent, not on the like a machine thing. Okay, so in a complex adaptive system, agents respond to their environment by using internalized rule. So we internalize, we have our own internally. And of course, اعمل في كل ميسر لما خلق له. Here Socrates as well says, know yourself. We need to know ourselves. Okay, this is the famous, of course, James Reason model, where there's boundaries or layers, and then of course there are gaps in the list, and whenever they are aligned together and reaching the patient becomes materialized. But really it's very limited, and because it's just a one-way system actually, and in reality it is not. It is from here to here, and also from the provider backwards and forward with the patient, because they are in the middle and they are the one actually controlling everything. So there is a limitation here, and actually in literature, he does. I mean, he suggested that the knowledge gained from the study of this model can be adapted to healthcare. But at the same time, he warned that healthcare was a more complex, and it is true. It's complex than any other industry. The complexity enhances the potential for errors, or increases the chance of avoiding them. And it's very true. So, it's been criticized, this model, and I do agree greatly with this, that, recent caution that the model was a simplistic simplification, and there is the individual is actually not part of it. Here, cognitive biases. If we look at cognitive biases of our providers, there are actually this research is about nursing. I've already done one and published for residents, and one for physicians and nurses as a comparison. I've done one also for pharmacy and so on and so forth. So we need to look at cognitive biases, okay? Because when it comes whether it is routine or rule or knowledge, we react differently, okay? And because the time doesn't allow it, even the very old actually video called Just a Routine Operation, and even very highly skilled people three. There was one ENT consultant and two anesthesia consultants, and they made a simple mistake, and because they were actually under stress, and then the tunnel vision bias really hit them, and we lost the patient. So it's cognitive biases as advanced errors of flaws in judgment and decision making. And decision making can be if we make an autopilot with, I'm not saying simulation can, but of course, simulation can make autopilot where, but we need, of course, invest in scenarios. But it is actually sometimes the same patient or the same disease, that you have the patient gender, age, comorbidities, and so on and so forth, will affect your judgment. So cognitive biases frequently inhibit our ability to, or willingness to change even our mind. So you have someone with a certain percentage rate of of course, there are some clinical psychopathy, will actually not change their mind and insist on doing or for that disease and making a diagnosis error. Whereas another physician will not. And we have to take into account these variations. In fact, when I've done the pharmacy, it was amazing that how even pharmacists choosing a certain medication with certain actually side effects, whether it is disability or even death or mortality, they were different in their selection based on how they construct or their personality traits and emotional intelligence. So safety and quality of care are not only a matter of technical skills, scientific knowledge and guidelines. On the contrary, contemporary medicine often faces obstacles lie outside the pure medical realm, being intrinsically due to the way a human mind works. There has been actually many models and investigation in the literature about human factor, and looking at these systems. You have the organization, and then you have the supervision, and of course, the interaction between the system and the human, and then the human by himself. And actually, these models showed, they looked at all the interaction and which one that will produce more or affect more the accident or the incident. And they found the human and safe act as an individual, not as being affected just by the system. Okay, and of course the organization does have, but here, as you can see here, maybe 18% and some 48%, but they've awarded the interaction, and then the 100% for unsafe acts. Another model, actually, in different paper, same actually results. And a third one with the IPSGs, the International Patient Safety Goals, and then looked which one and how it can be affected, and looked at the amount of impact of the system and the facility and the human. And they can see that, by individual themselves, they can. And that's why we have really little success with time, that from the last 20 years with the famous where is human, and we're still not actually any better, to be honest, and it's an increase. In the United States, it was 6.5% of all inpatient, and now it's almost 9%. And similarly here, we can see the three colors, the pink and the yellow and the beige, if it's the correct one. And you can see there's the how it's affecting actually errors or accident, and there's the interaction, which is the pink one, which is fine, and you've got the system by itself and the individual by itself, and this is missing. Okay, we're only looking at maybe the interaction. I'll speed up here. This one is actually more than almost 200, at least, cognitive biases. I'm not saying each one of us has 200, but we definitely suffer from a lot of these biases that affect how we look at the world, and how actually we interact with the patient and our peers, and how the communication or miscommunication can happen because our perception. And actually, some people from the 4 papers that I published, that certain traits can actually make more errors than others. As you can see here, where in A, there's the factors of culture, religion, language, you name it, age, gender of the provider. Then the trait and the emotional intelligence and the mindfulness and the intrinsic, traits. And then you have, of course, the organization, facility, the stress, the long hours, and so on and so forth. And then the communication between staff themselves. And then, of course, the patient, him or herself, affect. And all this really trying to, as an input to the provider, trying to take all this into account, but really affected by how he or she perceive and can take the stress, the perception, the biases, and then producing really errors. And as I said, there's of course, less errors in the skill base, but the rule and the knowledge is huge. The knowledge is literally 50% chance of making an error. I'll make it simple. If we take, I love simple really examples, at least myself. You've got the potato and you've got the an egg. The potato is hard, okay, and the egg is soft inside. And then you bring the environment, standardized environment of a boiling water. You put the potato in here, and you put the, of course, the egg in the same environment. The potato will become soft, okay, because its own characteristics, and the egg will become hard. So the environment affected these two construct differently, or these two human, or these two items. And so this is the human intrinsic factors, and then this is the system factors. As I said, this is the for nursing, this one for nursing and the physicians, and this is for the pharmacy that have done, and then this is the residents. And currently, I'm doing the actually the violence and bullying with the same mindset of the taken now, because we take consistent now and the interaction now, and want to take the construct of the patient, the personality traits, the emotional intelligence, the psychopathy. And the next one will be, of course, as it was Anita, will be for the endocrine and obesity for compliance and adherence. So in general, so to speed up, these are what's been found. They can affect how moral you are, how it can affect your decision making, it can affect your ethical stability, and definitely error rates, okay, and self-control. How you actually how much time you spend even on the social media. You're solving the problem, creating tasks. Errors here, nurse and patient relationship, autistic traits, believe it or not. I heard yesterday from the speakers about her experience as a patient with a nurse, and after a few days from getting a cold coffee, she offered, hot coffee. But this nurse will be different in the construct, in the way her personality trait than others. So we cannot really put them all in one cup, if you like, or one plate or bowl, and say we can actually have one environment that will be suitable for all. And again, error rate agreeableness. And when she, Anita, I think, talked about compliance and attitude and stubbornness, some of the actually it is because of the literature review for the compliance and adherence ones as well, and even for the bullying and violence about chronic disease. Actually, chronic diseases and compliance with the treatment. Talk about compliance, chronic disease by itself is affected by our personality traits, and so lower agreeableness can actually cause an issue for example, for having someone have an attitude. And when she said they're not scared because empathy is affected by the primary psychopathy, okay, compared to the secondary psychopathy. So you get patients where they don't really care if they get harmed, because This is their construct, okay? It's not something that they actually pretend. Burnout in nurses, there are variations, definitely, and it depends on their construct, okay? Why certain nurses are burned out, as the other one not. Emotional exhaustion and depersonalization, attitude, harmony, cooperative, selfishness, all this been actually covered in the 4 or 5 research. Of course, with depression, some will have more depressive, and impulsive, behavior, and even academically lower than others. And some can pick up skills quicker than others. So we need to know really all this. In conclusion, we need to invest. Organization really need to invest and understand emotional intelligence, personality traits, psychopathy, and be careful, because at the end of the day, if you want to say, for example, somebody in a leadership position and it has certain traits that actually might encourage a certain negative behavior in the area of for bullying and things like that. If we want to make change, we have to be realistic. We have to come to reality. We have to accept that being human does not mean being good, or being human is good only. No, human actually is a spectrum or a continuum of from minimum to maximum, and there are huge variation between humans. Okay, so we have to come to reality and say we are different, whether we are a nurse or a physician or a pharmacist or whoever they are, or any other really clinicians. So being different, that means intrinsically or constructively, means our behavior, our understanding, our communication will be different. And when we look in general of the Bell curve in any research, you've got the 68%, or let's just say 70% in the middle, and they don't err or they don't make any problem. But we have to look now outside that, because in all the world, on average, the rate is about 10%. Okay, so 90% success. Okay, if we're happy with 90%, we have a problem, because the 10% actually is costing us billions of in money and in life. So we have to really stretch out to these, I don't want to say minority, but these reality that they do exist. And then when it comes to remember the little girl and fish and the father, the big discrepancies, because the high management or the quality or whatever, they making a system change, okay, and then they expect this to fit all. Thank you very much. Over to you. Thank you. I hope I'm
Thank you,
within the
Dr.
time.
Adel. Yes, everything is okay. Thank you, Dr. Adel, for this great, amazing topic. Actually, I was so excited to attend your presentation that so it was really, really my pleasure. If there is any question to Dr. Adel, please just raise your hand or type it in the chat box. Okay, let's start with my 2 questions, then I will see the participants. Dr. Adel, in your opinion, what are the top 5 personality traits needed in healthcare and why?
Have you had any results? And sorry, I'm just reading the chat.
Okay.
Okay. Now, you're saying that top percent. No. Okay. Personality traits is this. We have 5 personality traits. Okay, 5 personality traits, and then we have emotional intelligence, and we have psychopathy. You have all these psychometric tests, right? Now, if we concentrate on, say, personality traits 5, the way I look at it, actually, I forgot to put it here, is simple thing is you have to think about it as a, in the studio for singing and all that, they have this huge room, control room, and it has many different dials. You can increase something and decrease something, okay? These personality traits, you have to look at it as a box, 5 of them, and a continuum or a spectrum of minimum and maximum. And the variations, a small variation will make us act differently, right? So in here, there are certain percentage rates for maybe linked to error rates, and there are certain ones for not really suitable for leadership, yes, and certain traits not for certain tasks. So really, when we come to improvement, sadly, we come to a Sentinel event. As I've been involved with the Sentinel event, I led the investigation for the last 15 years. It's my main task is you then try to make a system change regardless who made the errors, okay, to start with, and trying to think that it applies to all, which is something that, maybe we need to be careful with, because at the end of the day, as I mentioned, the 10% that's whether in leadership or errors or even in pharmacy, if encourage you to read that. It was interesting even between pharmacists, how they have chosen certain medication, okay, with different side effects based on their personality traits. So we have to take that into account when we look at if we want to reduce medical errors, because they're not actually decreasing. Any other question? Sorry, there was a
Yes,
question
please.
in the
Thank you
chat.
for answering. Yes, my first question. The second question is, what are the qualities of emotional intelligence in nursing? Briefly, please.
I think really it's better to read because the papers. I said to you, you have my details. Anyone can actually WhatsApp me. It's easy. It's okay. I want to make sure something here. I have to stress this point, okay, very much so, because one of my leadership position is I'm responsible for the behavior committee in the city. So I deal with behavior issues as independent from all these specialties, and we had a lot of success in it, and that's why I'm doing this bullying research. What I'm trying to say here is we have to be just and stay away from stigmatization, right? It's not about stigma or making a box for nurses or a physician or residents or pharmacists. What I'm trying to say here is we need to understand our staff and their challenges. So we do not stress them if for certain skills or certain tasks, because it's beyond their ability. So I cannot really answer it on here because it's in the paper. But my point is there are certain traits, yes, certain actually within emotional intelligence, for your information, many dimensions, and one of them is self-control. So we need to look at maybe self-control and see how the certain different staff scores in it. And it can give you an indication of how he or she will behave, or under stress or under whatever. So what I'm trying to say here is organizations should invest. It's an investment because worldwide there's a shortage of nurses. I'm talking about shortage of healthcare, but nurses as well. And we have to really invest in our nurses heavily and admire them for their work, but at the same time give them support to be where they can actually function better. This is my way of thinking, all right? And not to be used as a tool for blame or stigma, right? I hope I'm trying to be as politically correct as possible.
Thank you, Dr. Adilwi. Let's read the comments from Miss Maggie in the chat box. She's asking, have you had any results in developing staffing equipment or sharing their personality traits?
Staff equipment, have you had any results in developing staff equipment or share? I'm not sure I understand it well, to be honest. I hope Maggie can, but I'm not sure about staff, what is staff equipment. Is it physical equipment or to equip them with tools to actually help them with their personal traits? I'm not sure. But in general, Mark, if my understanding here is, yes, we need to invest in them to equip them with strategies to overcome their shortfalls. Yes, we can. Yes, we can. And this is a part of my recommendation on my papers. We can do that. But first, it's just like it's like anything. You need to know what you have. You need to know yourself first before you can invest on yourself, and others can invest in you. So we need to actually understand our staff, and then yes, we can empower them. 100% we can, but we need to make them aware. Sorry.
Sorry, I'm not sure
thank you, Dr. Adil.
you can hear me.
Yes. Sorry.
Yes, we can hear you. In 1 second, please. Can you comment to Dr. Adil?
Maggie, I can hear you. Maggie?
Yes, please, we can hear you.
Okay, hopefully they're unmuted again. We've been running courses like Jigsaw in our hospital group, and it's been very helpful in getting the staff.
You're muted again, Maggie.
I'm not muting myself. It's sort of automatically muting me.
Is it? Sorry.
No worries. So
it's not me. I'm not guilty.
No, I'm sure you're not. No. So what I was saying is we've been running Jigsaw in our group, and it's been very helpful in getting staff to understand their personality.
Oh my God.
How those personalities interact with one another in a stressful situation. So I was just wondering if you've done similar studies and you've started working with your staff, and whether that's had any positive outcomes.
Okay, good. Maggie, at the moment, to be honest, I'm trying to, you have to remember, changing paradigm or paradigm shift, of trying to change the mindset of healthcare or MOH, or you need first to prove to them we are different. You need to prove to them there's an issue, okay? Because you need really, one person cannot do it, or one organization. You need a top-down now to say, we acknowledge this, we're going to actually invest and help all our organizations. Because at the end of the day, I don't want to say any solution online here or to anyone, okay? Because there are a lot of commercial things that are available, and it can help. But first, we need to accept that, one, we are different. Okay? We are human, but we are different. Some of us have different personalities, okay? And these personalities have strengths and weaknesses. Once we accept that and we invest and understand this top down, and then accept that we can actually give certain role and certain then invest in money to say, right, this is how much we have. Let's invest on certain tools. All right. So really, Maggie, at the moment, I'm advocating for a huge paradigm shift for the management first, before trying or promoting any. Jigsaw is fine. Any other thing, it's fine. But I'm saying here is, I don't want you really to specify something here, and also I don't want to. When there was asked about certain traits, I think we should just read, be scientific, be mature enough to help. And really, seriously, in the behavior committee that I'm leading, for example, I'm responsible for the reporting system. I introduced reporting system study back in 2011-12, electronic one, and everything. And it's very confidential when the reporting comes to me. And I tell you something, really, if you invest and be genuine, okay, with nurses, you will empower them. Because when they report, only I got one incident where only once, okay, I'll show you how the powerful management leadership is. And she reported an incident, and she got actually one letter from her charge nurse, in her file. And I made sure that that letter, or when letter it comes out, and of course I've got the policy to back me up, so that'll be clear. And I really empowered that nurse. And since then, that was about at least 10 years ago. Honestly, since then, we have a huge report in safety, psychological safety. People are much happier. And even with the current one about the, because I established the behavior committee maybe 2016, and the current study is to evaluate, to research how effective, and it's huge effective for the our nurses. And inshallah, will be published maybe next month or the 1 month after. So we need to have a good, genuine leadership that want to invest in our healthcare providers and look at them as they are. They have their challenges, they have, and also they have their contribution and their strength.
Thank you so much, Dr. Adil.
Thank you very much, Dr. Adil and Miss Maggie, for your comments. Our next speaker is Miss Helen Ivers from UK. I'm passing her the stage to deliver the speech on how to make a difference. Miss Helen, the stage is yours.
Thank you. It's nice to see you, everybody. Dr. Adil, I love your session. I think that was just completely amazing. I am a clinician, I'm a nurse, I'm a paramedic, and I'm also a licensed partner with a company called Go Mad Thinking. I wanted to come here today to share with you my story. As a clinician, Dr. Adil, your session rings so close to home, because I do believe that if we can have clinicians that think differently, I have applied the methodology in my own world and it has saved my life. And I just want to share something with you today, a technique. I want to do a live workshop, so I want you to all get some pen and paper, because I want you to come along on the journey with one of the techniques that I have used. We use Think On when working with healthcare, and Go Mad Thinking, MAD stands for Make a Difference. So we work with leaders, we work with teams, we work with individuals, and we challenge leaders, teams, and individuals to transform results, solve problems, manage change, and they're using 7 proven principles. And there was some research done back 25 years ago by our founding director, and he asked the question, what is the simplest way to explain the success process that people naturally use to make a difference? And the results framework is one tool that I'm going to share with you today to help you make a difference. I'm going to share with you a video first, and this is from NHS Stockport, who we work together to help them make a difference during the pandemic. I'm just going to play the video now. Just let me know when you see everyone clapping. You should hear clapping for the sound. Can you hear that okay?
No, we cannot hear it.
Actually, no, we can't hear anything.
Okay. I'm not sure about the sound. So maybe I could share this with the presentation afterwards, the link to the video.
Yes, please.
That'd be okay. So this was a group of leaders that used the framework, the results framework that I'm going to show you today through the pandemic. And they were able to make extreme savings using the e-rostering system. But I will share the video with you. I can send the video after. This is why I'm interested in patient safety, patient improvement, and this drew my interest to this conference. And I really want to thank you for the opportunity, because as a clinical lead in an NHS 111 service for 10 years, throughout the pandemic, many traumas, coroner's court, different thing. We had the Grenfell fire within our local community in London. We had members of staff that had family or friends that perished in the fire. So as a clinical leader, supporting staff through lots of traumatic events, including the pandemic, everyone can you know, understand how it is very easy to burn out. So I burnt out back in 2021, and I met Go Mad Thinking just at the right time. And I used their thinking methodology, and it did help me think differently, and it did save my life. So I'm going to share with you today one of the tools and techniques that really, really helped me to make a difference. And I'm sharing with you on the bottom corner a QR code, which if you're interested, I run lots and lots of live sessions that are free for any leaders, any teams. Healthcare is my main passion, as you can imagine. And I really, really want you to be able to make a difference by thinking differently. So please scan the QR code if you're interested to join me for further sessions. But today I'm going to show you how to make a difference using the results framework. So these are the 7 key principles that were found at the research. So there was about 4,000 hours of data analyzed to find out what is it, the components that help you make a difference. Now, you make a difference all the time. You've made a difference today coming to this conference, and you have used and applied these principles. So when you want to improve patient safety, some of the sessions I've listened to over the last couple of days, reduce maternal deaths, to be able to improve communication, to be able to improve safety culture and create a just culture, whatever it is you want to achieve. I want you to right now to think about something you want to achieve at work. It could be something that you're currently thinking about, a new project. I want you to write out in box A, I want you to write these boxes out on a piece of paper. And I want you to think about, in the work-related example, a project, a goal, a difference that you want to make, which might be something to improve, something to change, or you want to achieve something in your work area. Then I want you to write that down as your work-related example. I then want you to write down 6 small boxes numbered 1 to 6 underneath that work-related example. And if you wish to, you can use a personal difference you want to make. If you want to improve your health or family life or anything like that, you can also use one of those examples as well. But I'm going to take you through 6 of the principles that are the thinking elements, and I'm going to get you to give yourself a score in each element of the results framework. And then we can have a look and see what elements you need to improve to help you make a difference. So I'll just give you a couple of seconds just to write out the boxes so you can follow me on the journey to making a difference, okay? So I'm going to explain each of the principles as we go along, and it will be, the first one will be the reason why. So when you think about the difference that you want to make, what you want to achieve, change, or improve, the first step is having a strong reason why. And so this is your level of motivation. It's your energy that you give to this task. It's about how strong you want to make a difference. So for your scoring for box number 1, I want you to think about 10 being the only thing you think about. So you get up in the morning, you're thinking about it. You go to bed at night, you're thinking about it. It's a strong reason why. So you'll give yourself a 10. A 1 would be, you're not really that bothered. If it happens, it happens, but you're not bothered. 1 would be a low score. Or you could give yourself a score anywhere between 1 and 10. So think about how strong is your reason why you want to achieve this. And then you give yourself a score in box number 1, a score between 1 and 10. A score for your work-related example and a score for your personal task, if you want to choose that one. Okay, so box number 2 is defining a goal. So a 10 score here would be if you have written down your goal whether it's written down on your calendar, it's written in an action plan, but the goal is written down, that it's really specific to what it is you want to achieve, that it's measurable. So it's an auditable evidence of how you've achieved this. So imagine me coming to your workplace and you could show me something that would evidence that you've achieved that goal, and you've got a calendar date. So not just December 23, but the 31st of December 2023, then you would give yourself a 10 for a score. If, and this is box number 2, if you haven't written your goal down, if it's just an idea that's in your head, it's a bit of an idea you're going to achieve, then you would give yourself a lower score. And this is box number 2 for defining your goal. I'm going to move to box number 4 because I want to show you part of the evidence and the research was that when we have our internal talk, when we want to achieve something, improve something, we need to have strong self-belief. So this is the belief that I can do it. I've got the skills, I've got the knowledge, I've got the time, I've got the confidence to achieve this goal. And if you were to score yourself for self-belief, then a 10 is high confidence. A 1 would be a lot of doubt. And in your head, you might be saying to yourself, I can't do this. So thinking about the achievability of the goal is really, really important, because you might decide then you need to really be more specific or change the date, and then your self-belief might actually improve. But for now, just think about how you feel about your ability to achieve this goal. Can you do it? If you've got high confidence, then give yourself a 10. If you've got a lot of doubt, you would give yourself maybe a lower score. So between 1 and 10. Give yourself a score now in box number 4. We're going to come back to box number 3. And this is the how. So we've looked at the why, we've looked at the what, we've looked at the can do. Now we're looking at the how. So when we look at how, it's about possibility-based thinking. So there's 2 types of questions. There's focus the mind questions, and then there's opening the mind questions. So when we want to specifically improve patient safety, or whatever the improvement is that you're choosing, it's really looking about opening the mind to generate lots and lots of possibilities. Anything is possible. And by generating lots of possibilities to include, what possible tasks do I need to do in order to achieve my goal? What possible resources might I need? How could I possibly communicate my goal? What possible reasons are there to involve others? So instead of thinking about specific people, it might be, what reasons? Do I need some finance? Do I need some IT? Do I need a particular skill to help me? The important things that we don't always think about in this area is about possible obstacles and how to overcome the obstacles. What possible risks are there and what implications? And going back to Dr. Adil's session about the human mind, you know, we make assumptions all the time, but it's important here to look at what possible assumptions might I be making about this, and also about what limiting beliefs I have that might be holding me back. And it's really good to have a bit of a think about those areas. So for the scoring, if you have done lots of possibility thinking about different aspects of the goal, if you have prioritized all of your good ideas and you've now got a plan of action with those ideas and you're prioritizing them, that's really important, then you would give yourself a score of 10, which is a high score. Or if you've just got a couple of ideas that are going around your head, you haven't really written them down or spoke to anyone about them, you would give yourself a lower score. Please give yourself a score now for box number 3. which is the how. This is the possibility-based thinking. We also do some exercises in our live workshops on problem solving and looking at lots of different possibilities. But for now, this is a score between 1 and 10 for how well you've thought about how to possibly achieve your goal. So this is box number 5. So this is about involving others. Usually we have go-to people. So we have our family, friends, colleagues, the usual people in our team or our team leader or our manager. So this is really, the research found that when people involved others around networking, collaboration, stakeholders, in the network, we've got a new network now within this Dubai conference that we can reach out to people who are experts. It could be that you've done some research or reading about the topic. That's also involving others. So the important element with involving others is that you also get their buy-in. Now, buy-in is crucial for this project to be successful. And it might be that you need to do some possibility thinking about how could I possibly gain the buy-in of these people to help me achieve my goal. So the score for box number 5 is about how well you are involving others outside of your normal go-to people, and you've achieved their buy-in already. So that would be a 10. If you haven't involved other people that you would normally go to, and you haven't got their buy-in, you would give yourself a lower score. So this is box number 5, involving others. So this will be for your work-related example or your personal example or both. So box number 6 is about personal responsibility, and the research showed that people who took personal responsibility, particularly when it came to the results being slow to come in, the achievements being slow, any of the areas that were not necessarily working to the timeline, that they took personal responsibility and they had a choice. They had a series of choices. In relation to choice, you have a choice about how much you're going to improve your skill, your confidence for your self-belief to go up. You've got a choice about whether you can be bothered with this project. You've got a choice about how specific you're going to define your goal and you're going to get your auditable evidence. You've got a choice about how much possibility thinking is done within yourself or within the team. And you've got a choice to involve others. Now, a high score here of 10 would be you're taking full responsibility. So just reflect on the project now. If you're taking full responsibility for this goal, then give yourself a 10. It might mean that you've got to meet people, you've got to change your deadlines, but you're taking that personal responsibility. If, however, you are blaming others, which again, we've heard in so many of the sessions that blame is a very, very negative, hindering aspect of getting team results. So where you're blaming others and not taking personal responsibility, you would give yourself a lower score, and that's box number 6. So how much or how well are you prepared to take personal responsibility for this particular project? And that's box number 6. So you've noticed there are 7 key principles, and the 7th key principle is to take action and measure results. So the 6 elements are the thinking. So it's about looking how much or how well in each area you've done your thinking in order to make sure that you maximize that success. And you can see that there are lines in between each of the principles. And the research demonstrated that actually it wasn't a process, but it was a set of principles with interlinking relationships for it to be successful. So I want you to now reflect on your answers, and a score of 4 or less in any of those areas will mean that you need to be able to do some better thinking, which means that you would do some more thinking around each of those elements. Could you please put in the chat? I would be really, really interested to know which areas you've got 4 or less. Is it reason why? Is it that you haven't defined your goal specifically with a calendar date, or you haven't thought about that auditable evidence that will demonstrate your success? Have you done enough possibility thinking? And if you've done the possibility thinking, have you prioritized your ideas to create a plan? Have you thought about your self-belief? Is your self-belief low? Have you involved others in the grand scheme of stakeholders networking?
Great, we have 2 answers.
Oh,
the
brilliant.
first
Okay.
answer is from Dr. Adel. I have 5, not 4, in box 5.
That's okay.
And Miss Maggie, lack possibility thinking.
Right. Okay. So Dr. Adil, 5 is fine. So 5 or more means that you are more likely to be successful, but need to do some more thinking in the areas that are quite low. And for Maggie, possibility thinking is a very common area that there isn't a lot of thinking done, because we generally go with the ideas in our head or ideas with the team. So some of the activities that we do with staff, particularly when you look at the video and see the impact of joining the staff within the goal, and thinking about, well, how could you possibly help us to achieve our clinical targets? So in the video, NHS Stockport went from red to green in their clinical performance indicators, and one team went within red to green within 90 days. So 90 days to achieve a clinical target is immense. But it means that, as Dr. Adel said, you need to have the leaders involved to have that buy-in, first of all. But actually, when you get the team buy-in and they're doing all of these different elements of the results framework within their own area, it means that you can achieve success in a huge impact. And possibility thinking is really, if you come on one of my live sessions, 7 minutes, you can get, within a team, ideally you're going to get 20 answers for yourself, 20 possibilities, and you can turn a problem into a solution. So for example, I don't have enough time. If that was a problem within the team, you turn it into a helpful question. Well, how could I possibly create more time? And by answering that question and allowing your freedom of thoughts, anything is possible. It means that you can generate lots of possibilities. You eliminate the judgment, the evaluation, eliminate the thought, well, they won't be able to allow me to do that because it'll cost too much. You need to get rid of all of those thoughts and just think you're in charge of the project. What could we possibly do? And then by bringing the same question to the team, and if you ask the same question to generate ideas within a team of 10 people and they all get 20 answers to the same question, you've got 200 ideas. So in the training, what we did is we put a flip chart on the wall, and the matron wanted to reduce falls in the workplace. So the question was, how could we possibly reduce falls? And we left an empty flip chart, and very soon, as persons came along in the training and went, we had over 100 ideas for the matron how to possibly reduce falls. So this is a really, really powerful part of the framework that can be used in different ways in order to generate ideas for change. So you can also use this model to coach yourself, to coach
Miss
others.
Helen, excuse me for interrupting you, but time is running out. Can you end your speech within 1 second, please?
Okay. I want you to download the Thinking for Good app, because you can generate questions here and help your team to solve problems. It's called Thinking for Good. It's a free app. And I just wanted to show you that actually we can help change mindsets. We manage change and support culture change just through thinking differently. So thank you very much for listening. And I look forward to seeing some of you on our live workshops. Thank you.
Definitely, my dear. Thank you, Miss Helen, for your great and informative topic. Yes, Dr. Adel.
Hi, Helen. Well done. That was nice. That was a good one.
Hi.
Hi. Yes. Just three simple comments. I shouldn't say really point. One is I was worried I would say go mad. I don't want any more madness. You know, we have enough. But it is actually
It's make a difference. It's not madness.
And the second one is I was really I brought back memories Stockport, because I was the Stockport spinal injury research assistant in 1991, believe it or not. So I'm still young. I'm still 21 years old, but you know, I was 1991 doing my PhD as well as there. The third point, which is very important, can help the team. I mean, just to share with the everyone. I have a lot because I lead a lot of teams. Okay, and one of the things that's actually similar to your way of thinking here that I've done for my team maybe 10 years ago for making change or things like that. 3 H's, the 3 H's principle: head, heart, and hand. Head, heart, hand. Three H's. The head is for what do you want? What is it you want from me? The heart, why? So that I get involved. So what is about really is the logic, and then the heart is about why, so that I get involved and passionate, and then the hand is about how, the skills. So the 3 H's, similar to you, whatever, which is excellent what you have, but I do it. I teach everyone, and I need to get involved. You need to invest in these 3. Anything that I've noticed that you fail, like when I have introduced the reporting system, electronic reporting system, years ago in my organization, I had to address these 3 because one of them will stop the other thing. Because if people don't believe in it, they will not do it. Even if you tell them from now to whatever what we need to do, no, why? Okay, and then how? Because you need to show them how to report, how to report, how to do this, how to do it. So these 3 elements is very important. I thought I'll share it with you so that you know what everyone can benefit. Thank you.
Thank you. Thank you for the opportunity.
You are more than welcome. I would like to ask you to keep staying with us. I will welcome our poster presenter, Prof. Ruqayya Ad-Dabara from Morocco. I'm passing her the stage to deliver the speech on miliary tuberculosis, a report of 12 cases. So the stage is yours. Prof. Ruqayya, if you hear me, please can you share with us your screen? Okay, I think Prof. Ruqayya is not ready now. She will be with us after a few minutes. So let's move to our next presentation. Will be by Dr. Saida Wesley from UK. Passing her the stage to deliver the presentation on the RESPOND study using human factors and engromics to reduce failure to rescue rates. Welcome, Dr. Wesley. You're welcome.
Yes, I'll just share my screen.
Yes, please.
Can you hear me okay?
Yes.
Thank you. Is that okay?
Yes, it's okay.
Okay, thank you very much. Some very interesting discussions going on, and I'm so excited to be here. So I'm Dr. Sadia Wesley, and I am a Human Factors Research Fellow at the University of Oxford. Today I'll be speaking about the RESPOND study, and what we did in this program was use a human factors and ergonomics approach to reduce failure to rescue rates. It is a National Institute of Health Research funded project, which is running over 5 5 years, and we're currently in the 3rd year. So just to provide an overview of this presentation, I will start off with defining respond and what failure to rescue rates are. I will then outline human factors and quality improvement principles used in the project. I will then introduce respond, the current progress, results, and future work. So research on serious complications following major surgery shows that chances of survival depend on how quickly and how our clinical teams react. The RESPOND program combines a human factors and ergonomics approach to enhance response, escalation, and reduction to failure to rescue rates. Failure to rescue rates can be defined as the occurrence of death after severe, potentially preventable complications. Now, what's interesting here is that failure to rescue has been associated with hospital factors rather than patient characteristics. So it's factors which are not a part of the diagnosis. So the take-home message from this slide is that failure to rescue rate has been defined as the occurrence of death after a severe, potentially, and preventable complication. Now, human factors and ergonomics is the scientific discipline that uses theory, principle, data, and methods to enhance human well-being and systems performance. Now, when we speak about human well-being, of course, we do mean patients, but we also take into account staff, especially following the COVID pandemic and the low morale amongst staff. In terms of systems performance, we're actually speaking about the healthcare system. Now, this could be the macro system, which means in England, the whole trust, or a meso system, which is the surgical escalation unit. Now, what is very important in this project, and especially the human factors strand, which I will bring up a little later, is the concept of work as imagined versus work as done. Now, my PhD research is based entirely on this theory, and this is because I'm also a clinician, and this policy versus practice debate has always been a hot topic. So work as imagined is what managers, authorities, and planners believe should happen in the workspace. Work as done is what actually happens in the workplace. Now, work as imagined and work as done are divided by time and space. So, for example, if you're creating a policy, it might take you months or even years to get that policy implemented. Whereas work as done takes place at the sharp end of the triangle, which means work happens in minutes and seconds. So, for example, if you have a cardiac arrest come into the emergency department, the treatment would occur in seconds. So that's the difference between work as imagined versus work as done. Now, in practice, if we apply this, I'd like to outline a case study which took place within the Oxford group. So a porter was asked to transfer a patient to theatre for surgery, a routine task. The porter went to the ward, collected the patient as per policy. The patient was then transferred to the anaesthetic room where they were prepared, and a cannula was inserted. It was then realised that it was the wrong patient. Now, if we look at work as imagined, this is a workflow diagram of what managers and matrons believe that porters do. But in fact, what porters actually do are all of these tasks. Now, these tasks are different system tasks. So, for example, blue can be communication, pink can be technology. So that's just an illustration of the difference between work as imagined versus work as done. So in the RESPOND project, we wanted it to be human factors heavy. So we used a number of models and methods. So in the first year of the project, and in fact throughout, we are using the Systems Engineering Initiative for Patient Safety. Now, this is really big in the NHS at the moment in England. But what we've primarily focused on is the work system and how concepts such as tools and technology, organization, internal and external environments, tasks all affect the person who's in the center. And the person, as I said, is both healthcare staff as well as patients, and even goes to as well as their families and carers. We also used failure modes and effects analysis. This was to ascertain the human factors risks that take place when caring for potentially deteriorating patients. We also used the FRAM methodology, and this was to pick up the variability between certain tasks within the care process. What we also did, which is highly recommended in the human factors research world, is that we combined human factors and ergonomics, of course, with quality improvement. And this was because we wanted to explore the system and then redesign it to improve it. Quality improvement was used to understand the processes involved and identify variation. We also used quality improvement as a means of feedback, which was extremely effective. We used PDSA cycles once we co-designed our interventions with frontline staff. And every few weeks, we'd carry out PDSA cycles to improve those interventions. Another thing we did with quality improvement was that we created quality improvement projects for junior doctors. This was essentially just to get buy-in from junior doctors. So we had work taking place regarding Respond on the front line, and it was done within the team rather than by us, who were seen as external researchers. And this was one of our mottos, which really took off, which was prompt action saves lives. So what we did in the second to third year is we introduced our interventions. So we had patient involvement, system redesign, which was the human factors intervention, team strengthening, and then shared ownership. I will, of course, talk you through these interventions. So the patient involvement was a patient urgent helpline. So what we did, we carried out focus groups with patient experts, and this lovely lady is called Leslie Booth, Dr. Leslie Booth, and unfortunately she is a CA cancer patient who survived, and she led these groups. She's also a qualitative researcher, so it was really insightful to have her lead the focus groups. Now, this resulted initially in a system called Early 3S. So this was a phone line, it was a leaflet with a phone line which connects you directly to a senior nurse on the ward. After a few PDSA cycles and feedback, this is our final version. And what we've done here is that we've put on a red card, and we can, if the patients cannot use a phone because they're quite sick, or there's a language barrier, what the patients have been asked to do is to cut off this card and just place it on their table or bed, so the nurses around them know that they're not feeling right. Because of course, patients know their bodies more than any healthcare professional, and we really wanted to empower our patients through this intervention. Before I introduce the human factors intervention, there are a few more human factors models and methods that were used in order to create this intervention. So we use the concept of safety because, of course, patient safety is central. Now, in resilience engineering, this is a core theory in human factors. We have the concept of safety one. So safety one tries to make few things as possible go wrong and is quite reactive. Safety one views people in the system as a risk and a liability. And it is considered as quite blamey. Safety two focuses on looking at as many things as possible going right. Humans are seen as a very valuable resource in the system. And basically it looks at what goes right and let's capitalize on that behavior. So we combine, safety one and safety two in the next intervention. Again, we use SEEPs. Now we use SEEPs in a way to guide our focus groups, as well as the observations that I carried out on the hospital wards. So here are the theories that were used in the human factors intervention. The human factors intervention is called the resilient operating procedure because we got a lot of feedback stating that we need some guidance that's realistic and bottom up, so staff could relate to this. And this was one of the key problems when I used to work in the emergency department. I was expected to carry out certain policies, but they were not realistic. So, of course, we incorporated the work system from SEEPs, work as imagined versus work as done, resilience engineering in terms of safety. And then we wanted to have a standardized tool to streamline our response to deterioration. And of course, this had to be co-designed because we wanted it to be both a bottom-up and top-down collaboration. So the resilient operating procedure began with carrying out a number of focus groups, which identify the processes that occur when a patient is deteriorating. Now, the methods included hierarchical task analysis. Now, this was used to unpack, better understand, and map out work as imagined. Work as imagined was mapped out using the news to escalation policy, which is governmental guidance on how to care for deteriorating patients. We had individual discussions. This was a means of making sure that our methodology was rigorous. So these discussions consisted of member checking to identify that the data that we had truly represented what was happening on the front line. And then I carried out a number of shift observations. So I carried out eight shift observations. There were 12.5 hours, and we ensured that they were varied. So there was weekday shifts, weekend shifts, and night shifts. And what I used here was the SEEPS model to guide that observation. So this was the initial resilient operating procedure. And what we intended to do was have a number of cards to put on staff lanyards. So when they have a patient, they could refer to those cards. We also gave advice. This advice consisted of feedback that we got from nurses. So for example, they say nurses and doctors often have a gut instinct when they feel that a patient isn't right. So we actually said, escalate if you have that gut feeling. I think it was something along the lines of trust your gut. After a few PDSA cycles, of course, we redesigned the cards, and it's a 3-phase response. So we've got the monitoring phase, the alarm response phase, and the planning and delivery phase. What we intended to do here was actually create a sat-nav system, which gives staff, well, empowers staff to take a number of options to achieve optimum patient care. Of course, we did get a lot of staff feedback and pushback in terms of using the term resilient, because what staff felt was that we were kind of insinuating that staff were not resilient. And especially following the low morale following COVID, staff wanted uplifting. So rather than using the word resilient, which is based on resilient principles from resilient engineering, we changed it to surgical escalation procedure, and there was a dramatic increase in engagement and excitement. So that was a positive outcome. The third strand was team strengthening, of course. Now, this strand was based on the concept of MILF sport. So what the team did, they interviewed athletes and high performing military personnel, and they asked them what makes a successful team. Now, one of these teams we are allowed to say this, by the way, one of the teams was the All Blacks, and I think they interviewed their lead rugby player. I'm very bad with names, I apologize. And what they outlined was that they did a number of things that made them the best team in the world. So things included, we can't have people who drag their feet whilst doing their work. We have loads of away days. We socialize outside of work, and we have shared values. So we incorporated those principles into the team strengthening strand. So here's a picture of the away days, which were really successful. And during these away days, we had group discussions, which were really exciting. And what each trust did was create some values. So these are shared values. What we did with these values, we created them into stickers. So every day during handover, what nurses do now is get a sticker and ask what staff would like the value to be. So just say having a no blame culture, they would get that sticker and stick it on their handover sheets as a physical reminder that today we are focusing on this value. And then they would retouch or use examples of these values during their patient safety huddles. Just going to take a sip of water, sorry. We also used NoTex. So this is a evaluation tool used to observe non-technical skills, and it evaluates parameters such as leadership and management, teamwork and cooperation, and situational awareness. What we would do with this, of course, ask for consent before carrying them out, is that we would feed back to staff, and we could gradually see that staff were improving based on the feedback. We also had, and I think this is an excellent idea, I am slightly biased, is the concept of our kind of team. So what we had was this whole, we have a positive attitude, we support each other when things are not going wrong, and we have this shared value and shared support system. So our kind of team, the concept of that actually streamlined this. So we had a number of cards which would be used when a member of staff seems stressed or overwhelmed. So just say there's an emergency situation, the nurse and the doctor are not really getting on, a healthcare assistant or a support worker can just support them by passing them the card, which would remind them that actually we do see what you're going through and we will give you support later. So these are seen as very effective. We also have e-boards which constantly feed back to staff on how great they're doing and examples of using the Respond interventions and the kind of difference that they've made. The final intervention was shared ownership, and now this is more directed to junior doctors. So this was a result of feedback from consultants as well as junior doctors. So this project started during COVID. We did set out for our 3 large hospital pilot sites, and the feedback was that junior doctors are quite lost at the moment. And that was because they were the COVID batch of doctors. So they didn't go to university or have a lot of practical placements. So they needed a streamlined way of communicating. Now, we do have SBAR, but they wanted something that was simple and just direct to the point. So we created the richer request tool. And if you can try this if you like, if you do share the slides. Doctors have stated that they could hand over in under a minute, which saves a lot of time and gets rid of a lot of anxiety. So the current progress, of course, is that we are now we're going into stage 4. This was a step wedge design, which I will explain on the following slide. So we have now obtained permission from 24 NHS trusts where we'll be rolling out the 4 interventions. We're super excited for this. And of course, we will be sharing our results throughout on Twitter because it is a live study. So to the juicy bit now, the current results are, so this is before March 2022. So this was pre-Respond interventions. As you can see, the response times to deteriorating patients were about 185 minutes. Now, once the interventions went in, it went down. It went down so much that it was probably half the time, which of course is very exciting for us, the patients, and especially the people who have co-designed the interventions with us. But unfortunately, after October 2022, the response times did slightly increase, not as much as they were pre-Respond, and that was because we had another COVID outbreak. So ward staff were really overwhelmed with COVID patients and, isolated bays and short staffing because staff were affected too. So as I said, we will have a 24 hospital randomized trial. It's a step wedge design. Now, this essentially means that everybody gets the intervention, but at different times. This brings me towards the end of my presentation. I'd like to thank all our funders as well as our 3 pilot sites. Of course, you can get in touch and learn more about Respond, or you could just get in touch with me. Thank you for listening. And do you have any questions?
Thank you, my dear Dr. Wesley, for this great presentation. Is there any questions or comments? Just raise your hand or keep it, type it in the chat box. We have one comment from Miss Helen. Outstanding presentation. Thank you. And
thank you so much.
Is there any questions? Okay, I think there is no more questions. Dr. Wesley, I will ask you to keep staying with us because we have a lot of informative topics with our great speakers. Let's move now to our next speaker is Dr. Eugen Tuaninos from Venezuela. Excuse me, apologize if I announce your name Not correctly. I'm passing him the stage to deliver the speech on management of generation and pain of dysgenic origin by an industrial injection of sulfate of magnetic clinical trial. Dr. Yujan, the stage is yours. Dr. Yujan, yes. Please, can you share your screen? Doctor, if you can hear me, just start your presentation, please. We can't hear you. Can you unmute yourself? Please, can you check your speaker? Dr. Yujan, we can move to our next speaker after you fixed your speaker, and you will be the next speech. So our next presentation will be by Dr. Evangelia from Greece. I'm passing her the stage to deliver the presentation on human error and management in OBG, and the next speaker will be Dr. Yujan. Dr. Angela, the stage is yours.
Good morning from Greece. How are you?
You are more than welcome.
It's my honor to be with you this day.
The pleasure is mine.
Can you see my presentation?
Yes, please.
Okay,
Go ahead.
thank you. In the next minutes, we will talk about human errors at management in gynecological and obstetric cases. 2 words first for me. I am ICU director, anesthesiologist, intensivist, and I adore, and extensively working on obstetrical anesthesia and its management in ICU. I have master in disaster medicine, and my second PhD is on prognostic factors in obstetric cases which were admitted in ICU. When we think about human error, we have to know that human error is more than meets the eye. Analyzing human error is a valuable tool in risk assessing both individuals and the system in which they work. Particularly in healthcare, we aim to reduce the risk of human error as much as possible to avoid adverse incidents which can significantly impact both patients and team members. First of all, we have the person approach, and what we mean with that. The first is the person approach to human error, which is the more traditional approach of the two. This focuses on the acts which are deemed unsafe. These unsafe acts may normally arise from what reason calls aberrant mental process, examples of which include forgetfulness and carelessness. Measures which aim to reduce human error in accordance with the person approach involve reducing variability in performance and holding individuals accountable for their mistakes. Systems which adopt this approach often result in individuals fearing making errors, and in many cases result in poor reporting of error when they occur. They also consider errors to be moral issues for which people ought to be published or sanctioned for when they arise. Psychologists refer to this as the just work hypothesis. On the other hand, we have the system approach. The second framework for addressing human error is to use a system approach, which claims that humans are fallible and errors are thought as part of life. They are seen as consequences rather than causes. They are not related to the morality of the individual nor human nature, but are rather due to upstream systemic factors. Reducing system errors is based on the premise that we cannot change the human condition, but we can change the conditions in which individuals work. For example, we can implement barriers on safeguards which will prevent adverse outcomes should an error occur. To sum up, we have to evaluate in both systems, and the person approach remains the most used of the two systems and fits into our intuitions to blame an individual should something go wrong. However, whilst this is the most widely used approach, it does have its drawbacks. Firstly, the person approach requires an open and honest work environment which has a culture of effective error reporting. This often does not occur when the person approach is employed, as individuals fear repercussions when mistakes are made. Not only does this create an environment in which errors are looked upon with fear, but it means effective reporting of errors does not occur with vital learning opportunities missed. Secondly, by focusing on the individual, it means that the error is looked at in isolation and with little or no regard to the system, nor how this could have contributed to the error. By looking at human error in this way, two vital aspects of it are missed. First of all, the human error can be made by even the most reliable and talented personnel. Secondly, mistakes for the most part are not random and fit into recurrent patterns. The same circumstances can lead to the same errors, regardless of which individuals is involved. The person approach therefore focuses too much on the individual and analyzes the incident in isolation of the system. All we know about the Swiss cheese model of human error. When we employ a system approach to human error, we can create defenses, barriers, and safeguards to help prevent human error from occurring. In this review, we have collected information about errors that occur in gynecological and obstetric cases. Mistakes are an integral part of every sector, but our task will be to recognize and report mistakes. This will prevent problems that may appear later. Organizations promote health professionals in announcing their mistakes to the person's family, but also to the person herself. Various error cases are described in demonstrating the variety of errors that exist. In this way, health professionals and other people, possible future patients, should understand that error is part of everyday life. Finally, health tips are suggested. A mistake is a common feature in healthcare. Mistakes of increased, moderate, or minor seriousness may occur, which cause serious, moderate, or minor problems, respectively. This most often happens due to negligence, stress, or semi-learning. Many unexpected problems are based on mistakes that occurred in the past and appeared later. This proves that usually many errors are not recorded, as we said before. The reason may be that the consent of those responsible for sanctions, the uncertainty about what really happened, or the ignorance of the use of the reporting system. The purpose of the reporting system is to transmit to the central authorities any errors that occur. These systems will be used by each hospital so that the health staff of the hospitals can be improved with the consequent improvements of the hospital itself. The patient, on the other hand, wants to know about the errors that occurred during, for example, an operation or a treatment. He also wants to know the severity of the mistake and how it can be treated, if it can be treated. This information will help solve the problem that has arisen, but it will be crucial for the quality of the services of the doctor and or the hospital itself. However, professional organizations such as the Institute for Health Improvement have guidelines that support open communication with patients after errors. For the last 14 almost years, the American College of Obstetricians and Gynecology supports patient information by doctors about error.
Excuse me, Miss Evangelia, but your slides are not moving. Can you check, please?
What can I do now? Where are you now? In which page you are? I'm sorry.
Actually, it's still keeping in the first page. Can you share it again and move the slides?
Okay,
Yes.
I'm sorry for this. I'm sorry for any delay.
Yes, now it's good.
Can you see
yes,
now?
Keep continuing, please. Yes.
Okay. This is that I said before. Maybe you couldn't have a picture, and I am here. In this way, the safety of each patient will be maintained, as well as the management of the error that may be in danger. More specifically, in gynecological and obstetric cases, errors often occur either individually in each category separately, or errors of missing the representation of a gynecological case as obstetric and vice versa. But this way, because obstetric accidents are about two people, are not one, any mistakes are more serious. When an error has occurred, obstetricians and gynecologists may support its disclosure to parents, the same many times, and intensivists, but they are concerned about the parents' reaction to the hearing and the risks that may arise. Despite this, trying to report the error and trying to improve the reporting method will bring the desired results later. Because maternal morbidity and mortality remain persistent challenges for the US healthcare system, efforts to improve patient safety are critical. An important aspect of ensuring patient safety is the reduction of medical errors. Mistakes that occur during the perioperative period can cause serious problems later, and so health staff should recognize and reduce these mistakes. They are broadly divided in two types of errors: latent and active errors. Latent errors indicate inadequate organization, which active ones must be dealt with individually. Now we will talk about some cases. I prefer to not talk about personal cases, but search and found some of them by literature. After searching with keywords error, mistake, obstetrics, gynecology, and health staff, we found plenty of articles from which we selected only 11, as we believe that the aim of the topic of this article and presentations and were within the last 5 years. In a study of pets in Norway, it was found that more than 65% of adverse reactions were reported by parents, while a much smaller proportion, almost 40% of cases, were reported by hospitals. 48% of the cases recorded were related to serious errors in the provision of healthcare or to system errors and not to individual errors. Most errors were detected in small and medium clinics by the supervisory authority. In a case of a neonatal death, which involved a child with a head injury and has therefore identified as suspected of child abuse, it was discovered that the characteristics of the injury could be attributed to violence. An autopsy revealed several leptomeningeal congestion and bleeding. Also, the microscopic neuropathological examination showed hemorrhagic purulent leptomeningitis. However, after a more extensive study of the incident, they found that the baby, according to the birth archives, underwent a cesarean section with vacuum assist. The fractures that the baby had on his head were combined with this type of extraction. Thus, the examination of a wound after the birth of the infant is characterized as a major importance as an omission of check of the newborn, resulting in death. In another neonatal event, in which the newborn was rescued in the operation room and then transferred to the ICU, an error occurred during fetal lung maturation. Then, the medical staff using a sulfate tried to cure it. The father's behavior during the transfer of the newborn to the ICU and after the announcement of the error was confusion and irritating, and for sure it was a normal behavior. In some cases, parents should be informed by a specialist so that there is an appropriate way to report the most times the problem is not the information, but how you express that you want to say to the other person. Much more when you have to talk to patients for errors. Errors have also been observed in the administration of drugs in the operation room. A lot of problems like this, and as I talked with other colleagues all over the world, it's very common. In cases of anesthesia, errors occur with medication and doses. Fewer errors were observed in hospital with electronic recording systems and barcode used in syringes. Information is stored in the system such as when someone is allergic to some stains and if a drug with the substance was to be administered, since the patient's data has been stored in the system. It will mean an indication that will not allow the administration of this substance. The cost of installing the system can be quite high and difficult to install by all hospitals and clinics, but this way will minimize errors and subsequent problems that may be caused. There are many times when mistakes occur when they are synonymous in the medical record. Thus, a medication that must be administered to a patient is administered to his namesake. It is even more serious if you mistakenly give medication to an infant who should not be taking this medication. In one gynecological cases, a 43-year-old woman had a constant vaginal discharge of watery, odorless, and colorless fluid for 8 months. The pap test was normal, as was her menstruation. The first diagnosis was urinary incontinence. In a second opinion, she received, and while the symptoms worsened, the ultrasound revealed hydrometral and papillary endometrial lesions. The hysteroscopic biopsy taken showed endometrial adenocarcinoma. This unusual form of cancer was initially misdiagnosed as urinary incontinence, was diagnosed by ultrasound, which was not performed in the first case. The most common symptom is bleeding in the postmenopausal period, but any other particular symptom that occurs in a woman should not be ignored. Early transvaginal ultrasound examination and endometrial sampling under hysteroscopy are recommended in any suspect case of cancer. The most common errors in the study were the delay of bleeding transfer to the operation room and the reduced to zero familiarity with the administration of prostaglandin for uterine atomy. The following are the wrong techniques of cardiopulmonary rescutation and dystocia. This is followed by the delayed administration of blood products, and finally, the inappropriate avoidance of episiotomy in a case of shoulder dystocia and the extension of the hip. In another case of a 25-year-old woman was 33 weeks pregnant, she was complaining of severe abdominal pain when the fetus was shaking. The diagnosis was peritonitis. An emergency laparotomy was performed, and the live baby was found with plaquental elimination in the eye and small intestine. This case asked doctors that abdominal pregnancy remains a differential diagnosis for painful fetal movements. It's also worth noting that mistakes made in pandemics of the past, such as of the HIV, should not be repeated. And not only we have another pandemic the last years, because in that pandemic, the ban of breastfeeding eventually led to many more infant deaths than expected. For a better effect on the health of infants in the midst of a COVID-19 pandemic, skin-to-skin contact and breastfeeding should be promoted. It is also worth mentioning that although the errors in radiology are less and less as the years go by, there is research related to obstetric ultrasound. It presents errors that occur at the study level, but also the individual level. These two can overlap or be combined. In any case, these mistakes must be eliminated. As we move in the end of the presentation, if, however, the patient does not accept the doctor's apology in case of error, it is normal due to his irritability and not acceptance of the incident. In this case, too, the doctor did the right thing, even if he did not have the specific treatment. At least in this way, he allowed himself to feel better and to forgive him for his mistake. We suggest all medical staff openly speak to their superiors, but also to the patient to whom the mistake was made about it. The error reporting system and electronic drug barcode systems are to be installed in every hospital and clinic. Healthcare professionals should examine the patient in more detail, but also work more carefully as well as faster to avoid mistakes. Finally, mistakes of the past that happened become a lesson so that they do not happen again. So we have to have an error management, and this has two components: limiting the incidence of errors and the creation of systems which can tolerate errors occurring and contain their damaging effects. In regard to the personal approach, this involves finding ways to prevent individuals making mistakes. In contrast, the system approach aims to create a comprehensive management program aimed at helping the person, the team, the whole workplace and institution. By employing these two pillars of error management, system can become more resilient to error occurring. Human error in healthcare, we said a lot of things in the previous before. We have to concentrating on 7 key categories which could cause safety concerns: institutional context, organizational and management factors, work environment, team factors, individual and I mean staff factors, task factors, and for sure, patient characteristics. The WHO released a conceptual framework for the international classification for patient safety, which identified contributing factors to adverse incidents. Contributing factors hazards are the circumstances, actions, or influences which are thought to have played a part in the origin or development of an incident or to increase the risk of an incident. Examples are human factors such as behavior, performance, or communication. System factors such as work environment and external factors beyond the control of the organization, such as the natural environment or legislative police. More than one contribution factor and or hazard is typically involved in a single patient safety incident. Summing up, from the identification of the incident that we did, we conclude that mistakes happening and continue to happen until today and will continue to happen in the future, unfortunately. Errors are observed which are usually due to ignorance of the error logging systems. Dealing with mistakes, unfortunately, is based on hiding and not recording more of these incidents due to fear. However, promoting awareness of any errors that have occurred is very intense by organizational committees. After all, there is no one who is infallible, and this should be understood by both the patient and the medical staff so that the best possible discussion in case of error happens. Also, health professionals should understand that reporting error is part of their job and their dignity. Home message is incredibly important to consider within healthcare. Firstly, we must employ a proactive approach to prevent errors before they occur. Secondly, we must take into account near misses and any incidents which occur and reflect on what led to the error and how it can be avoided in the future. This is a vital part of risk management and clinical governance. By reducing human error, we can increase the standard of healthcare and reduce the risk to patient safety. Thank you very much for your time. I hope not to bother you and to make you tired. I hope you hear me, not talk alone.
Thank you very much for your great presentation. If there is any question or your comment, just raise your hand or type it in the chat box. And actually, there is a comment from Miss Maggie. Thank you for this valuable lecture.
Thank you
She
very
thanks
much.
you. Thank you for your time, and I will ask you to stay with us. Let's move quickly for our next poster.
Just a comment. My very best wishes to all for continued success to your work and your personal lives. Thank you for your time.
You are more than welcome, my dear. So let's move quickly to our next poster speaker, Dr. Alvarez Gonzalez from Mexico. I'm passing here the stage to deliver the speech on evaluation of the surgical safety checklist proposed by WHO used in pediatric patients' clinical audit. Dear, the stage is yours.
Okay. Ooh. Oh, hi. Okay, can you see the presentation?
Yes, please. Yes, of course, we can see it.
Okay, perfect. So just give me 1 second. Okay, now it is. So basically this project, this poster is about a quality improvement project, and it was the title is evaluating an improvement of WHO's proposed surgical safety checklist for adults that it's been used in the pediatric patients and one of our hospitals in Guadalajara, Mexico. So basically give me 1 second. Sorry about this.
Excuse me, your
It's just
slides are not moving.
They're not moving. Yeah, sorry about that. Just get to see if this is better. Okay, now it's better, right? Oh, sorry about. Okay, so basically the summary about this, the purpose is this was a prospective study that was conducted by a team of doctors and nurses that wanted to evaluate the content of the surgical safety checklist that was currently implemented in pediatric surgical patients. So our main objective was to identify areas of opportunity to improve and create a new checklist adapted to specifically our pediatric population. So this process aimed to enhance communication among the different healthcare teams that were involved in the pre and post-surgical process, and obviously with the point of reducing preventable associated problems that by using this checklist could be achieved. So the impact that we were looking for, it was to provide a greater patient safety during the preoperative and the post-operative event, and well, with the aim of achieving a recovery with a lower probability of complications or possible sequelae associated with failures in communication between all the teams involved in delivering healthcare. So this was a team effort between surgeons, anesthesiologists, medical residents, medical interns, and nurses. And this project worked from the 15th of January to the 18th of May of last year. So the next one. So, and briefly, it was this new surgical safety checklist was proposed by WHO, and we were using it. The one that was proposed, we were using it for pediatric patients at our hospital. This previous checklist was around 40 standardized questions that aimed to verify the basic safety measures were taken before proceeding with a surgical intervention and after the surgery was performed. But the problem was that this checklist was not specialized for pediatric patients. It was incomplete, and it lacked certain essential variants that were unquestioned or uncorrected with different healthcare teams involved, and with the family or the patient. So, as I said, during the month of February, there was a questionnaire that the questionnaire that was used in the operating room was observed in each pediatric surgery, and that was with the point to identify the context and variables to propose a new checklist. So we wanted to see what was already there, and then evaluate and see what could be improved. So with different teams of collaborators, we consider the new checklist called the HCG Pediatric Surgical Checklist that we came with. So once that checklist was proposed, we implemented it in all the pediatric surgeries performed during the month of March as like a pilot mode, just to see how viable it was for our population. So this checklist, basically, in the preoperative stage, we wanted to add 9 questions that were focusing on verifying the requirements prior to surgery, confirming that the consents were signed, and that the patient, like, relative identity. Why? Because we're dealing with children. So it was important just to acknowledge who was the responsible, their details, that before it wasn't considered, it wasn't like we wouldn't look at. And we thought that this was an important step to reinforce, to recheck that this data was already written down. So just basically, as I said, name of the family member, the identity document, relationship, phone number, if they consented for blood transfusion, if they understood what was going on, if they checked moving like in the more apart from the family, to check in terms of the team if there was availability of the blood products and if the consents were signed. So in the intraoperative stage, we wrote down 5 questions that aimed for looking at the physical presentation of the patient before the surgery and rectify that all the material prior to start were already there. So simple things that, like, if there was any jewelry or any accessories in the wrist, ankles or the body were removed. This because, well, we've seen that previously there was some times that they wouldn't check and they will forget that the patient will be carrying this kind of accessories or jewelry. So this will delay or make it a little bit unsafe for the surgery to go on. If all the material was functioning, if the sterility was being confirmed, gauze sponge has been counted. So this is part of what WHO, obviously, a checklist it's already implementing, but just to complement it. And any doubts or anything regarding the instrument, the materials. And for the post-operative stage, there were 4 questions that focus on ensuring the proper follow-up after surgery. And this was basically, where would the pathology, the specimen will go, if only applicable. If the patient, where specifically was the patient, you would expect that patient will go to everybody would know that, oh, CCU or the ward, but sometimes there was a lot of miscommunication before. The reason why we thought that this was an important question to add to this new checklist. If the note was elaborated and it was already included in the records, just to prevent delays with giving the instructions to the nurses and what was going on after surgery, and if it was delivered to the patient, to the staff as well. So basically, this wanted to just to prevent the whole this new checklist contained around 25 questions that were applied during the month of March, and like I mentioned, is basically briefly just to follow up in case of an emergency. We had the details and the information ready, just we wouldn't lose time of like finding out information that previously wasn't taken. So with this checklist, it was easier just to see the list and see the details and just go for it. If the consents when signing, physical presentation of the patient, sterility, the material sterility and the preparation of the equipment, the localization, rectifying and communicating with the different teams if the things were done. So the outcomes were that we verified, we came up with this new checklist, and it was to basically just verifying the accomplishment of essential procedures needed prior to surgery. We would expect that this should have been done before, but for some reason, there were little things that were missed. The reason why we wanted to come up with this new checklist. And as I mentioned before, that it was basically based on the observation process that we did prior to this project to see there's a problem and we need to acknowledge it. In this new checklist increased a communication between all the team members and ensure that essential tasks were performed during the prior and after the surgery. So this initial approach demonstrated that healthcare professionals became more aware of details that previously were overlooked, and obviously facilitated to a quick access for the patient's information. So after this cycle, we decided to run a second cycle just to see how, after implementing this for this month, this new checklist, how the people feel about it, and how we did, or if we needed to improve it or add more questions. So during the second cycle, we present this project to the committee, and there was positive feedback about it, and they mentioned that it would be interesting to add another few questions that we sometimes leave behind, and it would be relatively important to add. So we came up with a new checklist that just added a few more questions focusing on, for example, in the preoperative state, 3 questions confirming the requirements prior to surgery. If the patient has been fasting, we would think that was a must, but sometimes that a question that you need to ask, but sometimes people will just forget about it and then just assume that they've been fasting for the past 6-8 hours when they haven't. They forgot, they were not told, and then problems could happen after. So if the studies were taken and if the elastic stockings or the bandages were placed in the extremity just for thromboprophylaxis. In the intraoperative section, we just had one question that would help, complement to prevent delays in the emergencies, like if there was a vascular access for blood components, that in case we would need one, if we already identify where would it be. And in the post-operative, it was one question focused in ensuring the communication between the medical team and the patient's family. So if the outcome of the surgery or everything has been updated, it has been updated to the patient, to the family and the patient as well. So, like I said, it was a total of 32 pediatric surgical, 32 questions that we tried to implement from the April 15 to May 15, May 15 of 2022. And it was, in a nutshell, basically just ensure patient was fasting prior to surgery, confirm that bloods were taken and the images were, the studies were there in case we don't have that much electronic system. So sometimes you need to have the things physically and those could get missed. So, and obviously will delay the surgery itself. Verifying thromboprophylaxis, re-ensure that the measures have been taken, vascular access, and the patient's family, we have updated them. So at the end, we came up with this surgical checklist, version 2. And as we said, it was basically to rectify these routine activities. They the healthcare professionals who were using this checklist or were needed to record to this kind of checklist, they mentioned that they promoted better communication among all the teams, and it was easier just to go and look for what was needed and have it right away rather than look for it. And obviously it enhanced the communication and the relation between the patient, the family member, and the team. So after we reviewed this new checklist, it was decided to be implemented in our department, in the pediatric patients that will go under surgery. So this is the one that it was used before. This is the one that it was the WHO, but it's a simple one. But like I said, due to the need of creating a more complex one, just to ensure that things were done, that's the one that we came up with. Well, this is in Spanish, but it was just basically to promote that sense of communicating and between everyone who is involved. And this is, well, it's a little bit blurry, sorry, but this is just a translation, but that's the one that has been used. And that's pretty much. Thank you very much for your time.
Thank you, Doctor, for your lovely presentation. If there is any questions or comments, can you please type it in the chat box or raise your hand? Actually, I have one small question. What's the importance to have an evaluation for the surgical safety in the healthcare field?
So what we've seen, obviously, this checklist as the one that WHO has suggested, and all hospitals follow, is to ensure that the patient's safety, ensure that minimal things that sometimes can miss, they're acknowledged, and that we have to, they've been acknowledged. So the reason why we create this one is because this is an adult one, and we thought that for pediatric patients, there are simple things that sometimes can be missed, and we will assume that we will know them, as like, have you consented the patient? Yes, we know that, but have we rectified that has been done? Have we rectified that minimal things that could be preventable have been done, so we can, like I said, prevent rather than treat?
Thank you very much for your comments and answering my questions. I would like you to keep with us, because we have a more extra 3 amazing speakers, and hope you're enjoying your time with us. So our next speaker will be Dr. Yujan. I have introduced him before, and I wish your speaker is working. If you can hear us, I will pass you the stage to deliver your speech on management of degeneration and pain of diagnostic origin by intradistal injection of sulfate of magnesium clinical trials. Dr. Yujan, the stage is yours. And I know you can't speak English, so please, you can speak English slowly. Yes, now it's your turn. Can you check your speaker, please, because we can't hear you? One second, please. Dr. Eugene, hello. We are unable to hear you. Can you please send us your recorded presentation? We will upload it into your tone. So, Dr. Eugene, when you check your speaker, just get back to me. I would like to announce that we will go for a coffee break for 10 minutes, then we will start our speech again. Keep in touch, please. So welcome back everyone from the coffee break. Let's continue our the online sessions for today. Our next speaker is Mr. Rami Al-Khalatiti from Saudi Arabia. I'm passing him the stage to deliver his speech on importance of training medical team on the electronic health record system. Mr. Rami, the stage is yours.
Assalamu alaikum warahmatullah. Thank you, everyone. Thank you, Ms. Amal, for this conference. It's really my pleasure to be with such a group of experts in their efficiency. So my topic for this year is the importance of training medical team on the EHR. And this importance comes because the most important data in the system going to be as input from the medical staff. So we have to be sure that all the documentation that they enter are entered according to several standards. That's why last year I was talking about the health informatics and the importance of how the organization can choose their EMR. And now we come to the most important thing after you choose your system in your organization. So each department or each health organization providing medical services, they will use their EHR or EMR. So when they choose this system, they have some goals and objectives they have to reach. Some of these goals are revenues, some of these goals are to gain the accreditation just from the accreditation organization, just like JCI, and in my country, Saudi Arabia, Saudi Central Board for Accreditation of Healthcare Institution. So when the market of EHRs, EMRs, actually they propose the features that their system has. So this is will let the stakeholders choose to take this system because of the features. For example, my organization, they adapt one of the best electronic health records in this world. So after 3 years of applying that, we realized that it's not all about the system itself, and to get the full benefit of applying or adapting that system is to train the medical staff and also share with them the importance of each information that they will enter in this system and how they will retrieve it, how will they use it with different technologies, just like IA, and also how to utilize it in reporting and visualization of the reporting and the data. So it will show the whole efforts that this organization provide. After they apply all of these tools, they will be able to measure their goals. So they will be able, by the tools that are provided by the system, to measure their success and also measure what's the goals that they have achieved because of adapting that system. So my concern about different departments, the best systems are integrated together. So it's not only a medical file that used by the medical team, but when I'm talking about EMR, I'm talking about organization system that include all the services all around the patient in one place, just like the eligibility, which include the identity and registration to identify the patient and provide all the admin forms for this patient for identity. After that, the information. This information should be available and also integrated from the patient side. So wherever the patient is taking any service around the organization, this patient will be identified in the same time and everywhere. Also, the diagnostic services, how I can diagnose the patient. For example, when we have patient in the outpatient clinic, when the nurses collect the vital signs and the main complaint, then this should be registered somewhere that the doctor can see in the same time to start evaluating and diagnose the patient until the patient turn comes. So this is one of the features that available, but if the medical team are not trained to do it, so you are losing the features that you expect or you have seen the proposal that it exists. Also, the usability, when the IT department evaluate the usability from the user, evaluate the usability of the system from the user side and also the patient side. The last one is the productivity, and this is the best part because whatever information you enter to the system, it should be able to be retrieved and visualized as reports, so I can know what is the productivity for my staff, for my department, for the whole hospital. So I can measure my KPIs regarding the reporting system included in this adapted system by the health organization. According to our survey that we did last year, this is measure the usability and how easy they can develop the system from their side, because some of the systems or most of the systems, they allow the user to upgrade their systems according to their needs and according to their usability. So as we can see here in the survey that the medical team are the lowest percentage to develop their work. And actually it depends on different circumstances. But as we can see here that the admin side and the ancillary services, just like the lab and X-ray, they improve around 60% because they have developed lots of features that they have, and the team was response to this changes. While the medical team, usually they stuck with several standards that they cannot pass because some of the features, if it's not capable with the international standards, then it will not be passed. Just like, for example, to be clear, when, let's say, a resident write a medical report for a patient, then the patient should take it immediately. But if you will follow the JCI and SIBAHI standards, no, this medical report should be accepted and signed by the consultant for the clinic. So this is something we cannot develop. We cannot make it, for example, directly from the resident or the fellow that see the patient. Last thing here, the use of the patient, how the patient can reach their information through the application, or maybe the communication directly by the phone, or coming to the desk and get their services from there. So I have main points here for the survey. When we are talking about the usability, providing features and displaying them by the shoppers is not sufficient to reach the goals of the organization to adopt the electronic health records, because they always show you something just come from their high experience or long experience in the field. But when you buy features that it's not useful for your organization, then your expectation will be low. The vision and mission must be imposed on the employees in the facility, and senior management must share the goals that the facility wants to reach by adapting this system. For example, we should share between the staff why we are taking, for example, the survey from the patient to evaluate the service. Basically, just to measure the quality of the deliverables. Then also each department branching out from the top management must link its goals to those higher in the organization, and ensure that all task service those reach those goals. So this is one of the surveys that we just want to measure how much the physician they learn from the sessions that we provide as a system. And after just like 3 years from using, we can evaluate the entry of the medical staff. So we did this study on only one department, which is outpatient department, and only one type of the users, who's the physicians. Then we just visit them during the visit, and we evaluate what they are doing and if it's appropriate, and if they fill appropriately all of the things that they have learned in the regular training. So this part of the survey is measure the knowledge of reviewing the history, just like what was the main diagnosis for this visit and also the previous visits. What are the lab results for the previous visit? So it's just measure the knowledge of the physician, how to review the history. Then the second part is focus on the knowledge of documenting, how the physician can write the progress note, how they can make order, just like order for lab, order for radiology. And also here, just like using the phrases or the smart text that saved already as when you mention just a number or a letter, then the whole sentence will be appear. And also how to refer the patient for another specialty. Then we have this third part, focus on the knowledge of placing orders, just like how to make a new appointment, order a new appointment, how I can give sick leave or watcher leave, renew the prescription. It's all of this orders based are trained for the physicians in their regular training. So this is also measured. Then the fourth part focus on the physician knowledge of co-sign the visit, how they find the notes that written by the fellow or the resident, and how they can sign it, how they can review it, how can they decline it for any reason. So this was the fourth part. Then the last part focus on physician knowledge of manage and communicate. Review the result message that comes from the lab or the X-ray, or even the pharmacist when, let's say, the dose is not right, or the dose is not this dose is not fit with this patient according to several standards that they have. So how they can communicate without calling, without sending the patient. They can communicate through the system, and this is one of the features proposed and also configured for the users. So it's also here measured. Then I was asked which better to make that assignment for training depend on the organization itself, or comes with the system. Actually, what's happened now, always the training budget rejected, because the organizations think that the system is easy and the users can learn from themselves, and they can practice more and they will know the system. And this is not true. So most of the systems now, they include the budget of the training from the contract with the organization, and this is the best solution. When you tell the health organization that there is no difference if you take the training or you leave it, it's up to you, but you will pay the same price, because they know that if they provide this service free as shown to the organization, they will accept. So what is the systems or the best systems do usually? They take care of this issue, and they are taking the training as their assignment, and they start train people from the same department. So they are credentialing them as credentialed trainers, and they will take the lead to do all the training sessions for their users. This is for examples for the training methods that can the system provide and support. The regular training, some organization, they link the access for the system with the training. Just when we say that no training, no access. So they can guarantee that the user, when they start their tasks, they know how to complete their task as well as they plan for. Then the reinforcement session, and I mean by reinforcement session, it's something extra after the regular training. Also, the systems nowadays providing the e-learning for just like the SIT training. If there is something will not change, so they just record it and that they provide it to the end user to see and to learn and apply without contacting with the training team. Also, the tip sheet was a really good idea that there is a document in the dashboard of the user. They can view how to complete one task exactly, just like how to discharge a patient, how to write a consent form, step by step, how to complete this task. Then also the extended office hours for it's usually used for answering the questions and also enhance the process. For example, one process done in 5 windows, we can put together the information and make it 3 windows rather than 5. So will be easier for the user. Training is very important. And this study that we did last year, it shows that there is no benefit if I buy the best EHR ever if there is no training, because no one will know about the features. Just like when you buy the last model of iPhone, but unfortunately you are using this device just for answer the calls, while you have thousands of features that you don't need, but you spend your money on it and you don't need it because the main idea is to answer your calls. So, do you have any questions so far?
Is there any questions, please just raise your hand or type it in the chat box. You can continue, Mr. Rami.
Okay, I just want to extend my regards to you, Ms. Amal, and for the team who's working
You're more than
on
welcome.
this conference. It was my pleasure to be with you today.
Mr. Rami,
thank you.
small comments, not a small question. In your opinion, why do you think that it's important to train the employee about how to use the electronic health record, and what will be the next step for that?
As the study that we did, that even when there is lots of features in the system that provided and proposed by the payers, I mean the shoppers, so they still cannot get the benefit because they don't know how to use it. And this is what consider as wasting for the efforts and the budget for this organization.
Thank you very much for answering my questions. I would like you to ask you to stay with us. Now we will go to the lunch, and we will come back after 1 hour to listen to our last speaker for today, Dr. Ali Al-Ahdal from KSA. So see you after 1 hour. Thank you very much.
Thank you, everyone.
So, Bismillahirrahmanirrahim. Good afternoon, everyone. Now we'll continue our last session after the lunch break. Our next and last speaker of the conference is Dr. Ali Al-Ahdal from KSA. I'm passing him the stage to deliver the speech on infection control consideration for dialysis patients in KSA. Dr. Ali, the stage is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear me?
Yes, we can hear your voice, doctor.
Good afternoon, everyone. This is Dr. Ali Al-Ahdal speaking from the Kingdom of Saudi Arabia. I welcome you all to our last session for this beautiful and excited international conference. We are going to talk about, actually we are going to discuss together. I would like to share my screen, but actually it's not sharing. I don't know why. Maybe you don't have given me
permission. You can share it now.
I had the access before, but now it's not sharing. I don't know why.
Can you click the green icon?
Yes, I can. And it's opened me a window. There is an entire screen sharing. I cannot do it. I only can share.
Open your PowerPoint presentation, then press the green icon.
It's already opened.
Okay, you have to do it by. Okay, you can share your screen to start your speech.
I cannot share my PowerPoint by any means. I don't know why. Maybe now I can. Okay, now I can. Yeah.
Okay. Yes. Now you can.
Okay. So we are going to talk about infection control consideration for dialysis patients. For those who are interested to know me, just to save time, you can just kindly take a screenshot for the QR on the right, and you can find my LinkedIn page. And I would like to welcome you all to the Saudi Society for Infection Prevention and Control through the left QR. You are cordially invited to join and follow our LinkedIn page. For today's talk, inshallah, we are going to present the value of systematic thinking in the infection control. I would love to not only to talk traditionally about infection control, I would like to share you how we can use our mind, our knowledge, and our experience to provide a good infection control program for our patients and our facilities. And then we are going to talk about the our patients and the risk for our patients, whether it's internally or externally, in order to classify or in order to understand how those risks actually affects our patients in the dialysis, in the hemodialysis department. Then we are going to share with you some of the scientific applications around the using the tool, the quality tool, the proactive FMEA in the infection control for dialysis patients. Then we are going to briefly discuss the some of the considerations actually in the facility, because as you may know that knowledge is there. I will just give you a guidance where to find the infection control instructions. My rule is to try to understand, try to illustrate and to simplify how we use our critical thinking in infection control and where we can find the information. Now, let's go to the first point in this presentation, which is the classification of the dialysis patients. According to the American Society of Anesthesiologists, any patients who has a end-stage renal failure and going for dialysis actually is classified as ASA class 3 and beyond. So it's a 3 or 4 or 5 or even 6, whatever kind. It depends on the other comorbidities that the patient has. So number one is the classification of the patient is the AS3. Then we are going to look for the microbiological nature and habitat of the skin. Our skin is full of microbiology. It's covered with microorganisms. Those microorganisms lives actually in a in a dynamic stage, and they don't overcome each other unless there is a problem, whether environmentally or whether in the immune system of the patient. If this happened, actually this stage is called dysbiosis. That means some of the microorganisms on the skin overcomes the other, and here we can have an infection. What is this has to do with our dialysis patients? Dialysis patients are more prone to have actually a dysbiosis on their skin because of the natural immune system of the patients, according to the disease, because of the physical ability of the patients. Most of the patients are beyond the 50s or beyond 60s, and their care of themselves or their care of their skin is different than those other patients who doesn't have the disease. And then because of the continuous use of antiseptics on their skins, actually it will start to change the habitat on their skins as a on the basis of microbiology. So this is the second thing. The third thing is that the access to the bloodline. Those patients, dialysis patients, have a direct access to their circulation, which means that it's a direct entrance to the whole actually system of their body, from the microorganisms outside to go inside, and they can reach any area of their body. That means that they are at risk of getting easy infections and easy entrance of the microorganisms to their circulation and to their other body systems. Now, the compromised immune system, the direct access of the circulation, and the microbiological nature habitat of their skin, of dialysis patients, all of these things are the external, internal. I'm really sorry, just give me a minute. All of these factors are the internal risk factors for the patients to get infection. Then we are going to go for the external measures. The water quality. Number one is the water quality. Every hemodialysis department is encouraged actually to do a test for their water on the basis of contaminants, on the basis of microbiology in the toxin and other ingredients on the water, in order to check the levels. Now, why is it important? There are different guidelines. You can use the AAMI or you can use the CDC, which is actually dependent on the AAMI. You can use the GCC guideline for the water quality for dialysis patients. There there are no differences between each other except for the bacteria and the endotoxin, as I remember, for the accepted levels and for the action levels that the action should start. But anyway, as we can see here, this is an example of a tested water quality in one of the facilities, and here we have the results that we got. We can check here that there is an increase in the chloramine levels, chloramine values, and there is an increase or start to increase in the bacterial level, also in the endotoxin level. Almost the endotoxin level is within the proactive action start. Why is it important to look for the quality of the water quality? Because actually the water that is used in the dialysis patient is going directly to run inside the patient's system and circulation system, which will affect the whether on the infection aspect or on the general health aspect of the patient. It will affect significantly those immunocompromised patients of the dialysis. We can have here, let's say, we can have here some of the symptoms that would affect the general health of the patient if the other ingredients are high in the water used for the dialysis. Let's talk about, let's say, fluoride. Or let's talk about, let's say, the calcium and magnesium. If the calcium and magnesium are high, they will have resulted in a syndrome characterized by nausea, vomiting, muscular weakness, skin flushing, and hypertension or hypotension because of the calcium, because of the mineral balance. Chloramine itself is associated with hemolysis and hemolytic anemia and methemoglobinemia. As you can see here, there are much different signs and symptoms that may cause only from the change in the water and increased minerals in the water and other ingredients. Let's talk now about the other two external risk factors, which are the healthcare workers and the environmental, which are causing the cross infections to the patient from outside or from the external source. Healthcare workers, they will directly actually directly cross-infect the dialysis patient through their hands if they are not clean. So the question is, did they actually perform a good and effective hand hygiene as recommended or not? Or they can actually take it from the environment to the patient, whether through the hand or through the other instruments or supplies that they can use for whatever procedure they are doing to the patients. So the third external, we are moving now to the third external part that would provide increased risk for the infection for dialysis patients, which is the types of vascular access line.
Excuse me, Dr. Ali, can you just move your slides? It's not sharing for us. We can see only the first slide, the objectives. Yes, no, perfect.
Only the objective?
Now we can see the cross infections.
Okay, so I will keep it this way, okay?
Okay, thank you.
Now we are moving to the third source of external infection for the dialysis patients. Which is the types of vascular access lines. Those access lines ranges from fistula to central lines. As we can see here, we are moving from the lower infection risk to the higher infection risk. We have the fistula As we can see in the picture here, we have the graph. As we can see here, those presents the lower infection risk for dialysis patients. Then we were moving to whether it's tunneled or non-tunneled central lines that actually provide a direct access to circulation through a major veins, which is directly connected to the heart, and then very fast they will spread to the whole body. This is one of the recommendations that we give actually to most of the hemodialysis centers, that kindly try to go with the fistula and graft before you move on to the central line, especially if the patient is chronic and is not on any kind of emergency state. Okay, how we would take all these risk factors and we implement it in order to develop a well-structured infection control program for the hemodialysis center. One of the tools that we can use in order to proactive and expect the failures that might happen and the increased infection, and to prevent those infections to happen, is the failure mode and effects analysis. Here we can find some of the published already work regarding the FMEA use for dialysis centers. We have different kinds of publications that happened. You can go, because of the time, you can just go to the DOI and check with the journal, and you can find the articles there. Actually, you will enjoy reading these articles because they have done a very great job there. Strategies to increase patient safety in hemodialysis. Application of model analysis system of errors and effects. This one is one of the most actually enjoyable article to read. They have done a very good and fine job. Now, as we can see, the CDC has their own approach for prevention in dialysis center as a bundle. I know you are familiar with bundles. So the CDC, they have their prevention bundles, and they have their maintenance bundles for the PSI, for the CLABSI, the central line associated bloodstream infections. It's not the time to go actually in details for this one, but you can just go and you can find it anywhere you can just Google it. One of the most important things for hemodialysis patients and for hemodialysis departments is the hemodialysis events. Now, those events will actually help the infection control practitioner in the facility to monitor and to execute a surveillance easily inside the patient. And they can also follow the patient, the chronic patients, when they go out, and inside the facility for any possible infections. Now, those events will start with the IV antimicrobial, administration, and then they will follow the patients if they will have a positive blood culture or not, and if there any kind of pus or redness or any kind of inflammation, source of inflammation around actually the access line, or if there is a combination between all of these, they will have they will check the earliest date of event for one of these. Now, what does this mean? You can go easily and find it in the NHSN for the National Healthcare Safety Network on the CDC webpage, and you can have a look more about these events. But I just would like to know that there are, as we have a surveillance program for the device-associated infections, we have also a surveillance program for hemodialysis patients, and this is a very important step actually to to follow. Most of the hospitals in Saudi Arabia, I believe, they did not start the hemodialysis events surveillance, except for the big hospitals. We in MOH, for 2 years now, we are trying to implement the hemodialysis events and embed it in the program, infection control program, for the rest of the hospitals, for the MOH hospitals. This one is for the immunization status of the patients, and in the same time for healthcare workers. We're talking about the HPV, HCV, and I believe that you understand how we are treating and dealing with the patients inside the departments, the dialysis departments, regarding the HPV and HCV. If the patient is for unknown serology, they will use a certain machines that is dedicated for unknown serology patients. And if the patients did this screening and they have proven to be free from the HPV and HCV, they will go for a dedicated machines that meant for patients who doesn't have the disease. Otherwise, there are machines which is specified for HPV and HCV positive serology for patients. So they must be divided inside the program, and they cannot share devices, the dialysis machines inside the department, to prevent the cross-infection. I'm ready to actually have any questions. I know this is a very short presentation, but because of the time, and I know this is the last day or the last session in the day in this beautiful and informative conference, and I didn't actually like to pressure to throw more information on you. So if you have any question, I'm more than happy to answer.
Thank you, Dr. Ali, for your great and informative topic. If there is any questions or comments for Dr. Ali, just raise your hand or type it in the chat box. Let's take actually, there is no questions. So, Dr. Ali, I have a small questions. You told us that there is okay, Dr. Rami Khlatit says, thanks a lot, Dr. Ali, for this informative topic. Really, it was amazing. I would like to ask a small question. Dr. Ali, you said that regarding the hemodialysis event surveillance in Saudi Arabia, there is no big hospitals that done this surveillance except the MOH. Can you mention for us, in your opinion, what's the risk for the actors, or what or where there is no hemodialysis surveillance till now starting?
Actually, what I said is the opposite of that. What I have said is that big centers and hospitals, they are providing the surveillance for hemodialysis events, but for the rest of the MOH hospitals, they actually did not provide this service for the infection control program in the dialysis center. And the reason is the reason is very easy and simplified, because most of the hospitals in Saudi Arabia, they lack, they are still short of infection control practitioner, and they are actually get the help from the public health employees. We thank them for their efforts, but this surveillance issue needs more professional people, and the events. I believe that the hemodialysis events needs more orientation in our hospital, so we can start with them softly, and then we can implement it directly to the hospitals.
Inshallah, hope so. Thank you very much, Dr. Ali, for your amazing and great presentation. I wish you all the best. Also, I would like to thank all of the chairpersons who sharing me the sharing. Dr. Sahar Muhammad from UAE, Dr. Barbara MD Groot from the USA, and Dr. Nagam Abu Shakra from Jordan. Also, I would like to thank all of the speakers. We will start with the keynote speakers, Ms. Abir Hamami from KSA, Dr. Badriya Muhammad Al-Riyami from Sultanate of Oman, Prof. Angret Hanawa from Sweden, and Prof. Lynn Gilman from UK. I would like to thank also Dr. Ahmed Al-Adawi from UAE, Dr. Adil Batawil from KSA, Mr. Robert from UAE, and Dr. Sami Abu Shawish from Palestine. Actually, according to the political and bad economic situation from Palestine, unfortunately, his visa is not existing. He was planning to join us in person, and his speech was about healthcare providers and beneficiaries' perspective about patient safety and UNRWA health centers in Gaza. So unfortunately, also as online virtually, he can't join us according to the Gaza situation. So we would like to thank him and hope next time he can join us. Also, we would like to thank Prof. Paul Okala from the USA and all of the great speakers. Dr. Ali Al-Adhal was our last online and the great speakers for the 3 days of the conference. The 3 days were more than amazing as usual, and I would like to take your time for 1 second and informing that UCG is organizing the 14th International Nursing, Healthcare Management and Patient Safety Conference in Dubai from 25th July to 27th, 2024 in Holiday Al Barsha. Also, our next upcoming conference will be the 14th American Healthcare Summit from November 15 to 17 in Texas, the USA. And in 2025, we will be on San Francisco and Dubai again. I hope we all meet again with new research and innovation in the field of healthcare. It's been an honor to be among such accomplished individuals and to be able to present my perspective before you all. Thank you and good evening, and I wish you a wonderful day. Now we will end the online session and hope you will enjoyed your attendance with us and hope to see you soon. Thank you for your times and thank you for joining us.